Mumbai branch. On behalf of CSI Mumbai branch, consisting of Dr. S.B. Gupta, our immediate past president, Dr. Ajit Desai, president-elect, then Dr. Vice President Dr. Kane and Dr. Brian Pinto, Uday Jadhav, Secretary, Dr. Anand Rao, Joint Secretary, Dr. Rajiv Bhagwat, Treasurer, and all our executive members, Dr. Ajay Mahajan, Dr. Bhavesh Wajibdar, Dr. Ratna Parki, Dr. Giri Sabni, Dr. Ramesh Dargad, Dr. Samir Pagar, Dr. V.T. Shah, Dr. Vaibhav Dedia, and Dr. Zakia Khan. It's my proud privilege and pleasure on behalf of CSI entire executive committee to welcome you all delegates, all the faculties who are going to take part in the talks, the speakers, chairpersons, and the panelists. Of course, today's program is totally conceived by Dr. Ajit Desai, and his team is working last 1 month behind this program. Dr. Ajit Desai, Dr. Niyar Mehta, and Dr. Zakia Khan. So it's our special acknowledgement to Dr. Ajit Desai for his efforts in, completely conceptualizing today's program and taking a lot of pain in, organizing this program. What I would request all the speakers and the panelists to stick to time, and so that we could have, enough time for the interaction. And of course, Dr. Ajit Desai is going to do the entire moderation. With no further ado, I would now request Dr. Ajit Desai to give, the overview and the classification of heart failure, and exactly what he intend to do for the next 3 hours during this webinar. Dr. Ajit Desai.
Thank you, Sada. Thank you very much. I think without wasting much time, can we go on to the talk, please? Yeah. Swapnil, can you put on the, yeah. Good evening, friends. At the outset, let me thank Cardiology Society of India Mumbai chapter for giving me, Dr. Zakia Khan and Dr. Nihar Mehta the opportunity to organize today's heart failure conclave. Well, I'm going to start the topic with an overview of the definition and classification of heart failure. Till date, or till very recent, we used to do the heart failure classification based on the functional class as class 1, class 2, class 3, or class 4 on the basis of New York Heart Classification. However, this has changed with the consensus statement which has come about the universal definition and classification of heart failure, which was published in the Journal of Cardiac Failure 2021 and endorsed by the Heart Failure Association of India also. What they proposed was the new definition for heart failure, wherein the heart failure is a clinical syndrome with current or prior symptoms and or signs caused by a structural or functional cardiac abnormality, which is determined by echocardiography with an EF of less than 50%, abnormal cardiac chamber enlargement, an E by E dash ratio of more than 15, moderate or severe ventricular hypertrophy, or moderate or severe valvular obstructive or regurgitant lesions. And these have to be corroborated by at least one of the following, that is elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion by diagnostic modalities such as imaging, either X-ray, elevated filling pressures by echocardiography, or hemodynamic measurements by cardiac catheterization. There are other clinical trajectory terminologies in the heart failure which have been proposed. First is the new onset or de novo heart failure, newly diagnosed heart failure with no former history of heart failure, worsening of heart failure, that is worsening symptoms and signs, functional capacity, and or requiring escalation of the therapies such as IV or other advanced therapies, and or hospitalization. Improving heart failure, where the symptoms and signs of heart failure or the functional capacity has improved. Persistent heart failure, where persistent heart failure with ongoing symptoms and signs and or limited functional capacity. Here they advocate not to use stable heart failure, instead use persistent heart failure. Heart failure in remission, where there are resolutions of symptoms and signs of heart failure with resolution of previous structural and functional heart disease after a phase of symptomatic heart failure. Here also they advocate do not use recovered heart failure, instead use heart failure in remission. We are well aware of these particular heart failure classification according to the LV ejection fraction, wherein heart failure with reduced ejection fraction is one where the LVEF is less than 40. Heart failure with mildly reduced ejection fraction, where the heart failure, the heart LV ejection fraction hovers from 41 to 49%. Heart failure with preserved ejection fraction, where the heart failure is associated with ejection fraction of more than 50%. Also, another terminology is heart failure with improved ejection fraction, where the baseline LVEF of about 40%, there is an improvement of about 10 points from the baseline LV ejection fraction. The stages of heart failure, there are 4 categories. First one is at risk for heart failure, that is stage 1. These are patients at risk for heart failure, but without current or prior symptoms of signs of heart failure or without structural biomarker or genetic markers of heart failure. These are basically patients with hypertension, cardiovascular disease, diabetes, obesity, known exposure to cardiotoxins, and family history of cardiomyopathy. Pre-heart failure is the stage B, where patients without current or prior symptoms of or signs of heart failure, but evidence of one of the following, that is structural heart disease, as evident by echocardiography of enlargement, wall motion abnormalities, and so on. Abnormal cardiac function, where the LV ejection fraction is reduced and there are signs of increased filling pressures or abnormal diastolic dysfunction, and also associated elevated natriuretic peptide levels or elevated cardiac troponin levels in the setting of exposure to cardiotoxins. The third is the heart failure stage C, where patients with current or prior symptoms and or signs of heart failure caused by structural and or functional cardiac abnormalities, where the patient may be in heart failure in remission with guideline determined medical therapy and modification of the risk factor, or continue to be in persistent heart failure. And lastly is the advanced heart failure or stage D, severe symptoms and or signs of heart failure at rest or recurrent hospitalization despite medical therapy or refractory or intolerant to guideline determined medical therapy. And these are the patients who might require advanced therapies such as consideration for transplant, mechanical cardiopulmonary support, or palliative care. So in summary, you have standardization of the heart failure syndrome definition. As I said, symptoms and signs caused by a structural functional cardiac abnormality and corroborated by at least one of the following, that is elevated nitropeptides, nitriuretic peptides, objective evidence of congestion by diagnostic modalities. This helps to enhance appropriate diagnosis and optimization of medical therapy and to achieve uniformity of care. The new revised classification of heart failure, as I said, at risk for heart failure, pre-heart failure, and advanced heart failure. It is easy to understand for the patients and the clinicians and clarifies treatment indications for pre-heart failure as well as heart failure. EF classifications, we are very well aware, depending upon the LV ejection fraction, it helps to standardize and clarify for treatment indications and emphasize for improved, not recovered ejection fraction. And the trajectories as suggested that you use persistent heart failure rather than stable heart failure, and heart failure in remission rather than recovered heart failure. Thank you very much. Thank you. I think we will go on to the next talk. I think that is going to be on echocardiography. And it's going to be by Dr. Nitin Burkule, and it's going to be of 2D echo in heart failure, the priceless tool for hemodynamic assessment in the heart failure.
Respected chairperson and my dear friends, let us discuss a case of heart failure where the resting echo and the Doppler give a tremendous insight into the various hemodynamic aspects. The universal definition of heart failure is that it is a clinical syndrome with symptoms and signs which are caused by a structural and or functional cardiac abnormality which is corroborated by either a elevated BNP or objective evidence of pulmonary or systemic congestion. So this structural or functional cardiac abnormality can be evaluated by echo and Doppler. So let us look at this case. It's a 62-year-old obese lady. The BMI is very high, around 43, and she is admitted with breathlessness even at rest, edema fit. The JVP is raised all up to the angle of mandible, significant hepatomegaly. She is a known case of well-controlled hypertension, diabetes, hypothyroidism, CKD, and she has a normal ejection fraction. She had early signs of NASH-related cirrhosis on CT, and she is having a very resistant, diuretic resistant anasarca. Now, this is a ECG which shows poor progression of R waves, and the X-ray shows hilar congestion, upper lobe vein prominence, cardiomegaly, right pleural effusion. Now, this is her 2D echo, which shows a very nice hyperdynamic left ventricle and right ventricle, which have normal size and function. There is a very prominent left atrium, and there is some rheumatic affection of the mitral leaflet with mild mitral stenosis. And this is the patient's GLS or the longitudinal strain, which is perfectly normal. So we are dealing with a patient who is congested and has got a perfectly normal LVEF and GLS, and so also RVEF and GLS. So she has a mild anemia. The NT-proBNP is 1,400. Creatinine is 1.8. 24-hour urine excretion is 1.2 grams of proteins, which is not in nephrotic range. Let us look at the right heart hemodynamics, and this is her IVC, which does not show any respiratory change of diameter, and it is quite significantly dilated, around 22 millimeters, telling us that the right heart filling pressures are definitely way above 15 mm of Hg. It is always a good idea to look at both the pleural spaces, and we can see that both the side there is a pleural effusion telling us that there is a systemic venous congestion. So definitely the right heart filling pressures are normal in presence of a normal RV size and RV systolic function. Now let us look at the patient's stroke volume. It is with the LVOT diameter measured here and the LVOT stroke volume measured from the LVOT velocity time integral. We get a stroke volume of 90 ml, which is quite high. And cardiac output is around 8 liter with the cardiac index of 4 liter. Now remember, an echo cardiac index of more than 3.5 liters per minute is very highly specific to diagnose a high output heart failure. So in the contemporary practice, if we see the major chunk of patients with high output cardiac failure come from the super obese patients. The next group is the cirrhotic patients, and the third group is the patients with the surgical AV fistula for hemodialysis. So why does the obesity produce high output state? Because there is an increased mass and there is more oxygen demand by this increased body mass, but at the same time the adipokines have a vasodilatory property. There is a excess microvascular density which reduces the systemic vascular resistance. There is a renal hyperperfusion causing more sodium water retention. So there is a plasma volume expansion, increased oxygen consumption, low SVR, increased cardiac output, and that leads to a high output heart failure. So as the systemic vascular resistance drops, the plasma volume keeps on increasing, and as the plasma volume increases, it raises the pulmonary wedge pressure. So let us look at the left heart hemodynamics of our patient, and this is her LA volume, which is 50 ml per meter square, which is very high because even the mean A +2 standard deviation, upper limit is 34 ml per meter square. So in absence of a significant mitral disease, a large LA tells you chronically elevated LV filling pressures. This is a mitral flow where the E is and A are almost of the same size, and which is unusual for a lady more than 60 years of age. And these are the E primes of the medial annulus and the lateral annulus, which are reduced, showing there is a reduced longitudinal function, and the E by E prime is more than 20. Anything above 15 generally is associated with a very high left heart filling pressures. Let us look at the left atrial distensibility. That, as you know, that with increasing LA filling pressure, the LA gets distended and there is hardly any further change it can accommodate with LV systole. So this reservoir strain falls as the LA filling pressure go on increasing, and here the reservoir strain is 25%, which is very low because normally is around 40 to 45%. So that means the LA filling pressures are high, and those are going to get reflected into the pulmonary hypertension. So the TRZ is around 3 meters. So the peak gradient is around 37 mm of Hg, and looking at the IVC, which is definitely 15 to 20 mm of Hg RA filling pressures, we get a PA pressure of around 55 mm of Hg. So if we use the AAC or the European Society criteria for diastolic dysfunction with increased LV left heart filling pressures, then we have to have 4 criteria: septal E prime less than 7 and the lateral E prime less than 10, E by E prime above 14, TR velocity more than 2.8, and LA volume more than 34. In the patients with normal ejection fraction, this picks up around 13.5% of patients with diastolic dysfunction, according to this study, with the patients with hypertension, diabetes, or coronary artery disease. However, if you replace LA volume by LA strain less than 23%, you can actually additionally diagnose 10% more patients with diastolic dysfunction with raised LV filling pressures. So what is the relation? In diabetes, as we say, the HbA1c tells you about the chronicity of elevation of blood sugar. In HepPep, the LA volume tells you about the chronicity of increased LA filling pressures. While in diabetes, the random blood sugar tells you instantaneous sugar. So also the LA strain tells you the instantaneous LA filling pressures. So now let us look at our patient again in this short axis, and one would look at this LA short axis and realize that the septum, the interventricular septum, has slightly flattened. Now, most of the time, the LV filling pressures being high, the septum will always be convex towards the RV. If it gets flattened like this, that shows you that the RV filling pressures have increased and the transseptal gradient has reduced. So in this case, the LV shows a high eccentricity index. That means this antero-posterior diameter is now more than the septolateral diameter. So that shows that the LV and RV filling pressures are getting equalized. Now let us look at our patient's mitral flow respiratory variation, and you can see that with inspiration there is a fall in the E wave, and with expiration there is an increase in the E wave. This change is almost more than 30%. That shows the ventricular interdependence in this patient. So also in the tricuspid flow, we can see with inspiration there is increase in the E wave, with expiration there is a fall in the E wave, showing the ventricular interdependence with respiratory variations in the left and right heart filling, which is reciprocal. If we look at the hepatic vein, if we look at this particular cardiac cycle, always in the hepatic vein, you will have a forward systolic flow and a forward diastolic flow. However, of the first beat after expiration, what we are finding is there is a reduced forward flow, and there is a mid diastolic and late diastolic flow reversal, telling you that with expiration, there is an increase in the RV filling pressures, and that may be because of the competitive increased filling of the left heart. So let us come to this concept of pericardial restraint in heart failure, and especially in the obese HepPep. The LV filling pressure that we measure is actually a sum of the transmural distension pressure of the LV myocardium, which depends upon the compliance characteristic of the LV myocardium and the pericardial restraint. So it is a sum of these two things. Then how do you gauge the pericardial restraining pressure? It is actually directly related to the right atrial mean pressure. So as the right atrial mean pressure increases, it tells you that the pericardial restraining pressure is higher, and they almost have a linear relationship. So the thing is, in obese HepPef phenotype, what happens is that not only because that there is an increase in the intravascular filling, that there is an increase in the heart volume, but also there is an excess of epicardial fat which forms layers and layers around the heart, causing pericardial restraint. And that is why what happens is the RV filling pressure and LV filling pressure start coming closer to each other, with the septum becoming flatter, and that is why you get the eccentricity index which is more than 1. Now this pericardial fat can be easily seen on the echo here, that you can see that there is almost 2 centimeter thick epicardial fat pad here, and so also you see that in the same patient's cardiac CT. So the thing is, recapitulating everything in our patient, she is a morbidly obese patient with anasarca. She has mild hypoalbuminemia and mild anemia. She has a heart failure with preserved ejection fraction, with objective signs of pulmonary and systemic congestion. She has high left and right heart filling pressures in presence of perfectly normal and RV volumes, ejection fractions, and longitudinal strain. She is in a high output state. She has a ventricular interdependence, respiratory variability in the left and right heart filling pressure, which is which is perfectly reciprocal, and this all is also explained by the pericardial restraint related to an excess fat deposition in the pericardium. This is one of the classical super obese phenotype of HepPef described by the Mayo group of Dr. Berry Berlog and Dr. Reddy. So let us prove this, and this is the patient's cardiac cath, and the coronary angiography shows perfectly normal left and right coronary system, and perfectly normal, no obstructive coronary disease. And let us look at the pressure tracings, and what we find, this is the simultaneous LV and RV pressure, and there is a diastolic pressure equalization, and with expiration there is a fall in the RV pressure, with no or slightly increase in the LV filling pressures, LV systolic pressures, and so also with inspiration there is increase in the RV pressure, and no change or slight fall in the LV systolic pressure. Let us look at the cath data. The stroke volume is 95 ml. We got 90 ml by echo. The cardiac index is 3.3, which we got almost around 4 liters. The pulmonary vascular resistance is 88 dynes, while the systemic vascular resistance is 770 odd. So definitely she has a low systemic vascular resistance. And if we look at the pressure data, the RA mean is 17, the RVDP is 16, the PA mean is 32, while the wedge pressure is 24. This gradient of 8 mm of HJ across the pulmonary vasculature, so she doesn't have a precapillary pH, and the LVDP is 20. The difference, this particular gradient from wedge pressure of 24 to 20 could be related to the mild mitral stenosis in presence of a high output, but there is almost a diastolic equalization in the 4 chambers, and the PA pressure is 140 by 60, and the saturation difference is saturation is 74%, mixed venous saturation is 74%. Now this patient, we put her in a significant weight loss mode, and let us see what happens after that. Now this lady went into a proper diet and a proper cardiac rehabilitation, and the gastroenterologist thought of putting the balloon, that space occupying balloon, in the stomach to get a weight loss, but we really did not need that balloon. Just the diet and exercise to help her to lose 30 kgs of weight. You can see the LV function is normal. The GLS remains to be normal. There is now no, the eccentricity index is perfectly normal. Now there is no septal flattening. You can see that the anteroposterior and septolateral diameters are exactly the same. There is no flattening of the septum. The E by E prime remains high. The E primes remain low as before. The E prime remains high. So the probably the left-sided filling pressures have not changed. There is absolutely no respiratory variation in the mitral flow. So the signs of pericardial restraint are lost. The LA volume remains high because that's not going to change because it's related to the remodeling of left atrium. The stroke volume also remains high. But however, all these signs of pericardial restraint are lost because that weight loss has definitely reduced her pericardial fat, removing the restraint, and her TR velocity has dropped now. There is no pH, and the IVC and hepatic vein now show respiratory. The IVC is now collapsing with inspiration, and the IVC size is just 11 millimeter. Filling pressures are normalized. Thank you.
Thank you, Nitin. Thank you. Wonderful talk. I think you have mainly emphasized on heart failure with preserved ejection fraction. Now we can I invite Dr. Shahrukh Gulwala and Bharat? Are you there, Bharat?
Yeah,
and,
I'm there, but the
Shahrukh, yeah.
video is stopped.
Can we have the video for Bharat and yeah. We have about 5 minutes left. Please go ahead, Bharat. You have any discussion points to be made?
Okay, in this case, you see, there's obesity as one of the implications, and the pulmonary artery pressures are high. Maybe it would have been interesting to see if a bubble contrast study also was done, and whether there was any shunting which was occurring. And so that is one point. And the other, the peculiarity is that the E by E prime, which is reflecting your pulmonary venous hypertension despite 30 kilo drop in weight, did not come down, and in fact it went higher than what was recorded earlier. So that seems to be a little bit of a conundrum actually.
Yeah, that's a perfect observation. Now the thing is, her saturation was always fine. So that's why we didn't do the bubble contrast, and I don't think there could have been any PFO opening in her case. Now the second question about the E by E prime. Now most of these patients with their long-standing comorbidities have already a lot of LV ultrastructural changes. So it is very unlikely that just a weight loss will reduce the LV compliance characteristics. But the weight loss has definitely reduced the pericardial restraint. So so my idea of showing this case was that in an HepF of an obese type, there is a double whammy. There are double trouble that you already have an HepF because of the reduced LV compliance, and on top of that, the pericardial restraint further raises your pressures, because the amount of pH that she had developed and the amount of right heart failure she had developed with her normal RV function could only be explained by this pericardial restraint, which absolutely vanished with the weight loss. But we won't expect that the LV compliance characteristic would change with just weight loss. I think it's probably too late. Their interstitial fibrosis has progressed. As you saw, the LA also did not regress.
Yeah. Nitin, there is a question by one of the attendees. If normal gradient between RA and RV is less than 1, why do we consider gradient of more than 3 as significant stenosis?
I did not get it. It is the.
It's on the chat box. If the normal gradient between RA and RV is less than 1, why do we consider gradient of more than 3 as significant stenosis?
Is it about the tricuspid stenosis?
Yeah, it's
yes, it's about tricuspid stenosis.
Mean tricuspid gradient.
Mean tricuspid gradient, yeah. Actually, the significant tricuspid stenosis, the mean gradient is 5 according to the ASC guidelines. That's by the Doppler across the tricuspid stenosis. But in this case, this was not a question because the RA mean and RV mean even on the cath you saw they're within 3 millimeters of each other. So this was not a question in this particular case.
Okay, Shahrukh, any points you want to make?
Yeah. No, very interesting case. I mean, normally we see many obese patients, but I don't think we look at them very carefully as Nitin has showed in this particular. So very interesting to learn from this patient. I have just one question on GLS being used in heart failure. Nitin, since we are doing GLS so much more often now in the last couple of years, we always come across some problems in our day-to-day GLS measurements. As in, eyeballing, the patient has a very low ejection fraction. And then when you do a careful GLS, you get a normal reading. Vice versa, you have a normal looking left ventricle ejection fraction on eyeballing, and like say in an athlete. And then you do a GLS and you get a low reading. And you're totally confused as to really one should believe that GLS reading or not. So how would you explain this paradox?
Yeah, actually the EF and the GLS look at two different aspects of LV function. The EF is entirely volumetric data. So it is just the difference between the end diastolic and end systolic volume. However, the GLS look at a unidimensional deformation. So actually these are two different characteristics of the same ventricle. In presence of a normal ejection fraction, if the GLS is dropping, actually it's worrisome, because that shows, because the most of the time the longitudinal deformation is governed by the subendocardial helical fibers, and most of the comorbidities affect the subendocardial fibers. So I think the drop in the GLS is a very early sign of something going wrong with that left ventricle. So I think, in case of a normal ejection fraction, I would very much believe on the drop in the GLS to pick up an early systolic dysfunction.
Okay.
Actually, there is a new index, Nitin, myocardial contraction fraction, which really which looks at your stroke volume upon the myocardial volume, and precisely these early cases can be picked up.
Excellent. Yeah, that is actually a very interesting, and it has got a lot of promise. But the thing is, to get that myocardial volume correctly, you would need a cardiac MRI. But that MCF is supposed to be the combination of both the ejection fraction and the GLS put together.
Correct.
And interestingly, the MCF cutoff is also the same as EF as 60%. So I think it's a very interesting parameter, and I think we look forward to it in future.
Yeah, Nitin, last question. There is a question from Dr. Zakia Khan. This physiology is very similar to constriction. How do you differentiate?
Yeah, true. It is very close to the regular post-inflammatory pericardial constriction, but it is not exactly the same. That even in the cath data, you saw that the movement of the LV peak and the RV peak was not as great as you would see in a tuberculous pericarditis. But it is really true. It is very, very close. But my important point is that on the echo, especially in the obese HepPef, just look at how the septum behaves. If in inspiration it is becoming flatter, think of pericardial restraint because of the obesity, and it has got the only way to lose it either by the weight loss, either by the physiological weight loss, or by the metabolic surgeries, and they are really helped by it.
Yeah, thank you, Nitin. Wonderful discussion. Bharat and Shahrukh also. Please remain logged on. Yeah,
Ajit, our MMC observer, Dr. Abhay Titke, joined.
Yeah.
So we'd like to welcome him.
Yeah, please.
Yeah.
Welcome, sir.
Welcome, Abhay. Yeah.
Yeah, I think we'll move on to the next talk, and that is going to be of Dr. Bhavin Jankaria. And, he has got a fabulous experience as far as cardiac MRI and CT is concerned, and he's going to give us an insight into the MRI and CT in heart failure. Bhavin, yes.
Hi, thank you for inviting me to give this talk, and I will speak on cardiac MR and CT in heart failure. Let's just get cardiac CT out of the way because, in heart failure, its only role clinically currently is to look at the coronary arteries if you don't want to do a regular coronary angiogram and to see if the heart failure is ischemic or non-ischemic. So there's nothing else to it. So let's stick to MR. And the indications for CMR and heart failure would be accurate evaluation of volumes and quantification, tissue characterization to find the cause of failure, and to exclude pericardial disease. Now, when it comes to ejection fraction measurement, we know that CMR is the gold standard, especially for clinical trials. In regular day-to-day practice, echo works good enough, but every time a CMR is done, it is imperative that the ejection fraction and volume measurements be given. So that's essentially how the measurement is done from the apex to the base on the short axis stack. It's a semi-quantitative method where the computer draws these lines along the endocardium and epicardium, and then we pretty much get the ejection fraction with all the volumes. Now, once that is done, we would also characterize the lesion or the myocardium using all of these techniques. Now, the commonest is late CAD enhancement, where gadolinium is injected, then we scan after 5 to 7 minutes. And then, depending on the pattern, or first of all, the absence or presence of enhancement, that tells us that something is abnormal. And then the pattern of enhancement that tells us what the potential abnormality is. Infarcts start in the subendocardial region and then become transmural and are territorial, whereas inflammation and fibrosis is often mid-myocardial or epicardial and then may become transmural, and they are non-territorial. So here is a patient who has acute myocarditis, a 30-year-old with acute chest pain 4 years ago. There is a reduction in the systolic volume function. We can see that on the short axis and the four-chamber. And then we can see this abnormal enhancement. It's mid-myocardial in the septum, telling us that this patient already has fibrosis. So once we see this, it gives us more confidence that something is abnormal. But what do we do when there is no enhancement? For example, here's a 26-year-old with postpartum failure, ejection fraction of 15%, large LV, and absolutely no enhancement. We can then use T1, T2, and T2 star mapping. Now, T2 star mapping is done predominantly in patients who have iron overload. So here's a patient who has biventricular failure or involvement. The ejection fraction is 50%, has thalassemia. And we can see using the T2 star how black or dark the myocardium has become. And this tells us that the patient has severe iron overload, which is the reason for the patient's heart failure. The other thing we do is T1 mapping, that is, measure the T1 values of the heart, which are typically elevated in fibrosis and edema and reduced in iron and fat involvement. So here's a 60-year-old with a dilated cardiomyopathy. We can see the swirling of blood within the LV cavity and how the RV is normal. There is no enhancement, and there is no edema on the stir, but the T1 is markedly elevated. On our machine, the normal T1 is 1295 milliseconds. So at 1407, we know this is high. So in the absence of edema, in the absence of overt scar formation, this represents diffuse interstitial fibrosis and carries an independent risk factor for poor prognosis as far as the future is concerned. We also use T2 and stir images predominantly for edema. So here is another patient who presented with viral myocarditis. The systolic function is mildly reduced. In fact, RV is also involved here. And we can see that while the T1 is high, the T2 is high, and we have edema on the stir, along with abnormal enhancement of fibrosis. So we have everything here, right? So we've got edema telling us that this fits in with viral myocarditis, and the fact that some of it will end up being scar tissue, but the elevated T2 and the abnormal stir give us some more information. So we can use all of this. The presence of uh, or looking at the cine images to see the abnormal systolic function, measurement of the ejection fraction, late CAD enhancement, T1, T2, and T2 star, and then see what the causes are. Now, the causes broadly can be ischemic or non-ischemic. And when we're looking at ischemic cardiomyopathies, we basically do viability imaging. We know that in a patient with an infarct, if the wall motion is normal, then the myocardium is viable. But if the wall motion is abnormal, then we need to figure out whether the involved myocardium is viable or not. So here's normal function, and here is a patient who has akinesia of the inferior wall, akinesia of the mid-anterior wall and septum, and then we need to figure out what's going on. So the principles are simple. All infarcts enhance, all non-enhancing myocardium is potentially viable, and all infarcted myocardium involving more than 50% of the myocardium is not viable. So we assess the areas of systolic dysfunction, the presence absence of infarction, and then make an assessment of viability. So let's look at one example. Now, in this patient, we can clearly see that the mid-septum and anterior wall are akinetic, extending into the mid-anterolateral segment. And so we map the wall motion abnormality on this chart. The same thing we do with infarction. So again, the mid-anterior wall and septum show transmural enhancement extending into the mid-anterolateral segment. All the apical segments are involved, and the basal anterior wall and anteroseptal segment. So again, it's all mapped out here. And then we make a viability assessment. Basically, if the infarct involves more than 50% of the myocardium, then it's non-viable. And so in this particular patient, the LAD territory is non-viable. And that's the chart. I mean, if the systolic function is normal, then there's nothing. If it's abnormal, look at the late CAD. If there's no infarction, obviously it is ischemic and potentially viable and hibernating. And then if the infarct is greater than 50%, it's non-viable. If the infarct is between 25 to 50%, we may have to do another test like a dobutamine stress, MR, or echo. What else can we do with infarct imaging? Look at morphologic abnormalities. This patient presented with acute failure and chest pain, and we can see this rent here in the septum in this patient who had an acute LAD territory infarct, and we can see the transmural enhancement here. This patient had come from a private nursing home elsewhere, and I think on the way back died. So that was unfortunate, but that's what else we can, this is part of what the other things are that we can see when we're looking at MR. So now let's come to the cardiomyopathies. We have myocarditis, granulomatous diseases, restrictive cardiomyopathy, hypertrophic, ARVC, and we've already looked at iron overload. Now, we are seeing this quite a bit these days. We're seeing acute manifestations of COVID, as well as patients coming 3 to 4 months later with just dilated hearts and reduced ejection fraction. So here's a patient who has severe hypokinesia of the anterior wall and anteroseptal segment, and we can see the edema on the stir, raised T2, normal T1, and abnormal enhancement, which will eventually present as scar tissue. Granulomatous cardiomyopathy is the term given to patients who have monomorphic ventricular tachycardia, abnormal enhancement, and lymphadenopathy. It can be due to sarcoid, which is the diagnosis made worldwide, but we know that in our country, TB also presents in this manner. So here we see this abnormal epicardial enhancement in the anterior wall and septum, and this biventricular systolic dysfunction. This patient had necrotic nodes, and it turned out to be tuberculosis. Here's another patient, akinesia of the basal septum. There is abnormal enhancement. The patient had lymph nodes proven to be sarcoid, and this patient, despite treatment, worsened. And you can see how the heart is more dilated. We can see the scar much better, and extensive biventricular enhancement that has progressed. Restrictive cardiomyopathy is associated with reduced diastolic filling, biatrial enlargement, and we get abnormal enhancement. The two common conditions are endomyocardial fibrosis and amyloidosis. Now, endomyocardial fibrosis has a subacute presentation. We see these arrow-shaped areas or abnormal enhancement of the membrane formation that occurs here. And that's quite typical when we see it in tropical countries like ours. In patients with amyloidosis, there's thickening of the myocardium with abnormal function. Now, again, we can see that there's a biventricular involvement, both atria are dilated, and then we have a markedly high or raised T1 and an abnormal enhancement with deranged contrast kinetics. This enhancement is transmural and it involves all four chambers of the heart. This is very characteristic of amyloid. The same goes for hypertrophic cardiomyopathy. When the hypertrophy is such that it leads to reduced function. Now, while there is obliteration of the cavity, you can see that there is actually hypokinesia with this septum predominant hypertrophic obstructive cardiomyopathy. And we can see here both the MR as well as the subaortic obstruction. But we do MR predominantly for the fibrosis, which we then quantify, and any fibrosis greater than 20% would generally imply the need for an AICD. Then ARVC, which is not uncommon, predominantly involves the RV, but can also involve the LV when we say that there's ALVC. And here we see this abnormal morphology of the free wall. There are pseudoaneurysms, abnormal trabeculation, and severe hypokinesia of the RV, and the RA is dilated here. The last thing that we need to do is exclude constrictive pericarditis. And we know that we can diagnose this by looking for the thickened pericardium, anything greater than 4 millimeters, pericardial calcification, biatrial enlargement, and septal bounce. Now, here's a typical patient who has a banana-shaped LV. We can see the constriction along the AV grooves. And on the CT, we showed that this calcification was actually a ring around the LV just distal to the AV groove, and this is reasonably typical of tuberculous pericarditis. Now, here's a patient who has a pericardial thickness of more than 4 millimeters. The systolic function is normal. There was nothing else. But if you look at the septum here, as the diaphragm goes down, you can see that the septum is deviated here into the LV. So that's septal bounce that occurs in the first inspiration with late systolic deviation into the LV, and that is reasonably characteristic of constrictive pericarditis as well. So to come back to the indications, the role of CMR in heart failure is to accurately evaluate volumes and to quantify for tissue characterization, where we use late gadolinium enhancement to see if there's fibrosis or scar formation. T1 mapping allows us to pick up diffuse interstitial fibrosis, also edema, and in patients with thalassemia and iron overload, we can use T1 to diagnose those as well, because the T1 values are reduced. Then we have T2 mapping and stir imaging for edema, and T2 star for iron overload. Then we can pick up the etiology, whether it's ischemic or non-ischemic. In ischemic cardiomyopathies, we basically do viability assessment, and in non-ischemic cardiomyopathies, we basically try and pick up the presence of, let's say, acute myocarditis, which we're seeing more and more now with COVID, granulomatous cardiomyopathies, hypertrophic cardiomyopathy, ARVC, etc. And lastly, we could exclude pericardial disease with cardiac MR as well. So that's the role of cardiac MR in heart failure. And as I said, the role of cardiac CT is really restricted to looking at the coronary arteries. Thank you for your attention.
Thank you. Thank you, Bhavin. Wonderful talk.
Thank
and
you.
some amazing videos of the MRI which you have shown us. I leave it open now for discussion. Dr. V.T. Shah and Dr. Anand Rao. Anand, are you there? V.T., are you there?
Yeah, I'm there.
Yeah,
Of
please.
course, the video is blocked, but
Can we have the
I hope
video on, please?
my audio is.
Yes, yes, of course.
Yes. Okay. Thank you very much. So, Bhavin, excellent overview of the role of CMR in heart failure.
Thank you.
And just couple of points. One thing about your comment of more than 50% is viable, non-viable. Now, is it something like 50% stenosis on the angiogram, which we see, which is a gray zone? And for that, again, we have to do some other test to find out whether that 50% really is a good cutoff. What is your take on that?
No.
Could it be 60%? Could it be 45?
We're measuring the thickness of the infarct in the myocardium. This has nothing to do with coronary artery.
No, I'm not saying. I'm just comparing a ballpoint like 50%.
Yeah, so it's 50 and
So
above.
the reason I will tell you is sometimes, we revascularize this patient and we see a improvement in function.
Yeah, but it's because no viability assessment is 100%, isn't it? So you still need to look at the overall picture and decide. I mean, if your myocardial wall thickness is, let's say, 10 mm, and you get a 60 or 70% infarct in a single vessel disease in a young patient without thinning or aneurysm formation, you might still go ahead and revascularize, isn't it? Whereas if it's a transmural infarct with 2 millimeter paper thin myocardium, what is the point? So all that has to be taken into account.
Now, most important point is about this MR. When we send patients, sometimes there is problem with breath holding, sometimes with some devices, atrial fibrillation, multiple ectopics. So what do you think situations or claustrophobia, I mean, most commonest. What do you think are the situations where you are unable to do it, or you would say better not do it? Like even low EGFR, I don't know. What is your cutoff?
No, so low EGFR meaning anything less than 30, then we would not give contrast. But because of T1, T2 mapping, we are able to do plain MRs in a lot of patients. So I can't do viability assessment. But if you send me a patient for COVID myocarditis or amyloidosis, I need not give contrast. I can manage. Claustrophobia, generally, we can give midazolam and some anxiolytic, and we can usually manage. Breath hold is a problem if typically patients who are in partial failure, we've actually had, once in a year, we have a patient who goes into failure in the MR. Borderline.
Just like echo, even patients come for echo and sometimes they land up in gross failure while.
So that becomes a challenge. But I would say that 90% of patients who are referred, we are able to manage. 10% sometimes we either can't do or we have to call them back again.
Yeah, Anand, go ahead.
Yeah, my question was same as Dr. V.T. Shah. Dr. Bhavin compliments on that wonderful lecture and those lovely images. The same thing, patients with atrial fibrillation and with intraventricular conduction defects.
Multiple ectopics.
AFib is not a problem. Ectopics are a problem. We still generally start doing the scan because we can do some real-time imaging and all that. But if there are too many ectopics, then we have to send them back and, we would tell you, please control the ectopics, put the patient on amiodarone, do something and send them back.
One more question.
Bhavin, one more question on the chat box. 1 minute. What are the treatment implications of MRI input in a patient who has got heart failure? And the second part is, what aspect of current optimal medical treatment will change with added input of fibrosis, scarring or amyloid extras?
So I'm going to throw the question back at Dhruman. No? I mean, you're the guy sending me the patient. So tell me, when you send the patient, are you able to, does it help you make any treatment definition? No, why? So I can understand where the question comes from. Because there was one paper that came out, I think about 2 or 3 years ago, where somebody actually tried to say, okay, we can see so much on MR. We can see so many beautiful things. We can do all of this. Does it change patient management? And that was specifically in the it's not in hypertrophic cardiomyopathy because there it does. ARVC it does. But does it, for example, change in myocarditis? does it make a difference? If your TROPs were elevated and your coronaries were normal, does it make any difference to go ahead and do this? And so in a highly specialized unit where they do a lot of echo very well, with contrast echo, with all, strain evaluation, perhaps CMR may not necessarily make a difference, but it all depends on where you are, what you do, etc. And so this question should be asked.
Can I make an
No,
observation?
Bhavin, what about sarcoid? Sarcoid you can assess after treatment.
Yes, yes. Granulomatous cardiomyopathies, it makes a difference because it's then
Yes.
from a diagnostic perspective. So it completely changes the way we approach the patient.
There is a paper, if you, in a non-ischemic dilated cardiomyopathy, if you have a late gadolinium enhancement, your EF is lower than 35, plus when you throw in your longitudinal long axis strain more than 10, minus 10, these patients have a higher incidence of having a sudden cardiac death or a cardiac event versus a patient who doesn't have a late gadolinium enhancement. So if you are really like looking closely and you really want to risk stratify that out of a subset, which patient is at higher risk, then you have some options, but you have to really go into detail.
Bhavin, last question. Question of any role of MRI in heart failure due to valvular heart disease?
Not really. I mean, the only time it helps is when the patient has shopped and gone to 3 people and the echo results are different for all 3. Then we use MR to see which one was right. But otherwise, echo is so good. Yeah. I mean, you don't.
No, but Bhavin, sometimes subaortic membranes or webs or somewhere
So specific
hidden things which echo cannot,
Yeah.
or maybe transesophageal patient cannot undergo.
Yeah, so specific instances, yes, especially in all the young adult diseases, even for example, post-tetralogy evaluation, you can't really do echo for RV and pulmonary valve. There we do cardiac MR all the time. So those kind of things, yes. But, let's take your 70-year-old with aortic stenosis, usually no. Once in a while, we get an idiopathic dilated cardiomyopathy where we are the first people to pick up an AR which is causing the DCM, but that's once in a couple of years, I mean, that kind of stuff.
Thank you, Bhavin.
Thank you, Bhavin. Thank you, Bhavin. Sorry to have teased you with some questions.
That's okay.
That is common as far as VT is concerned. So no issues about VT. Thank you.
And Anand also. For echo to VT, it will all come to an end.
Thank you very much. I think. Thanks, Bhavin. Thanks, Anand. Thank you, VT. Please remain on board. We'll move on to the next one, and that is by Dr. Jimmy Dalal, and that is guideline determined management of heart failure with reduced ejection fraction. And we have 2 of the panelists, that is Nazir Juwale and Sadanand Shetty. Yeah, move on, please.
Good evening. I'm going to talk to you about heart failure with reduced ejection fraction.
Hello.
Some of the new guidelines and thought processes. We all know the benefit of ARNI on cardiovascular system. As you can see from here, benefit in terms of all causes, cardiovascular causes, and even sudden cardiac death, worsening of heart failure, of course. The benefit that we have seen maximally with ARNI has been the improvement in ejection fraction, a reduction in left ventricular end systolic and end diastolic volume. So this reverse cardiac remodeling with ARNI has been one of its greatest beneficial effects. But there are certain patients who do not easily tolerate ARNI, and one of the main reasons for not tolerating it is hypotension, worsening of GFR, and hyperkalemia. We also know that ARNI can be started in acute decompensated heart failure. The Pioneer heart failure showed improvement in NT-proBNP and a significant benefit in terms of the final composite endpoint. Since we know now that we can start ARNI in acute decompensated heart failure, the Paradise MI trial was done, presented at the ACC a few months ago, with the use of ARNI in patients with acute myocardial infarction within few days, with ejection fraction less than 40% and or pulmonary congestion, plus any of the other risk factors as you see below. And this was compared with ramipril in this particular situation. What they found in the Paradise MI trial was that there was not real significant difference in the primary composite endpoint of cardiovascular death, first heart failure hospitalization, or outpatient heart failure. However, if you look more closely at the primary event and look at the cardiovascular death, heart failure hospitalization, and outpatient heart failure, you will see that there is a numerical benefit in terms of all these parameters as compared to ramipril, suggesting that though statistically significant values were not found and the trial was therefore negative, there was enough evidence to suggest that there was a benefit. And if you look at the last point, the outpatient heart failure, it actually reached significant values. Of course, moving on to SGLT2, we are very well aware of all the trials. The DAPA heart failure trial stands out as the most important and the most early one. It was use of dapagliflozin in both diabetic patients and non-diabetic patients. And the big outcome of this trial was that whether you were a diabetic or not, you had the same benefit in terms of the primary outcome. And also, in addition to that, there is 17% relative reduction in all-cause death. Also, the very interesting aspect of SGLT2, which became very apparent, was the benefit both in the diabetic group and in the non-diabetic group in terms of benefit in GFR. As you can see, there's initially about 10% fall in the GFR, but after that, there is a stable GFR compared to those who are not on SGLT2, where renal function continues to deteriorate. I think the benefit of SGLT2 in renal function dysfunction is an extremely important component of the benefits of SGLT2. And again, if you look at the DAPA heart failure trial, you can see that almost every subgroup benefits. So whether diabetic status or not is mentioned, renal dysfunction or not, whatever the systolic blood pressure, whether the patients were on ARNI or not, whatever the baseline ejection fraction, or even the heart failure etiology, it didn't really matter. All the patients benefited equally. The Emperor Reduce came soon after that, again with the efficacy of empagliflozin in, again, diabetic and non-diabetic patients. As you can see from here, the primary composite endpoint of CV death and hospitalization for heart failure, 25% reduction. Secondary endpoint of first and recurrent heart failure, 30% reduction. And second secondary endpoint, which is the worsening of kidney function, again, a 50% reduction. So very, very dramatic benefits of empagliflozin as well. And as you can see from here, whether the patients were taking ARNI or not taking ARNI, they have the similar benefit. Now, when you look at the journey of a patient with heart failure, you have, of course, the acute heart failure hospitalization mortality. And then you have post-discharge mortality, which is quite high within the first 3 months or so. And we particularly consider these first 3 months as a very vulnerable period of these patients with heart failure. And if you look at the Emperor Reduce trial or in any of the other SGLT trials, you can see that the primary endpoint curves begin to diverge very early. You can see within the 12th day, it becomes significant, and you can see a significant improvement going on with divergence of these curves. So the point to make is that the benefit of SGLT starts very early. And that is why there have been various propositions about the algorithms for treatment of heart failure with reduced ejection fraction. One which McMurray suggested was to start all patients with beta blockers and SGLT2 inhibitors. The reason being that SGLT2 inhibitors do not have a significant effect in terms of fall in blood pressure or worsening of potassium hyperkalemia, and therefore combination of SGLT2 with ARNI or with mineralocorticoids is better tolerated. And then, of course, you rapidly add all the other drugs onto the starting regime. The most important thing, of course, to remember is to start all the 4 pillars of cardiac treatment within the first 4 weeks. Now, one may well say that you need not follow what McMurray suggested. It's possible, and this is what I like to do, is to start small doses of almost all the 4 drugs before the patient is discharged, and then gradually increase the dose as they come to you in the follow-up. I didn't mention about beta blockers because we all know that beta blockers are extremely useful and absolutely indicated in patients with heart failure with reduced ejection fraction. Again, the point to note is that if a patient is on beta blockers and comes in with acute heart failure, the beta blockers often discontinue. And this, as you can see, can lead to problems. So please remember that if you discontinue beta blockers when the patient comes to you with an acute left ventricular failure, be sure to start it up as soon as possible. And again, to give adequate high doses of beta blockers, because high doses of beta blockers are related to much better reverse remodeling in patients with cardiomyopathies and ischemic heart disease. And again, of course, you mentioned about the heart rate control and the importance of beta blocker dosage again in heart rate control. We know, of course, that we can use ivabradine if the beta blockers cannot be increased further, but the optimal thing to do is to give a full dose of beta blockers before you move on to the use of ivabradine. And again, we must remember that when the patients are on ARNI or on SGLT2 and they come sick, they call a sick day guidance. They need to therefore stop these drugs. As you can see, medications like SGLT2 inhibitors, RAS blockers, ARNIs need to be stopped. But that has now been questioned. For example, the DICTATE acute heart failure trial started SGLT2 very early, dapagliflozin very early after acute heart failure. And it's possible, therefore, that it may not be so true now that SGLT2 inhibitors need to be stopped when the patient presents with acute illness of any nature. So, of course, you have to be careful of precipitating acidosis, etc. Then, of course, there are some of the newer trials, Veresegward, the Victoria trial, which again showed significant benefit in terms of patients who had heart failure with reduced ejection fraction, and we don't have it available with us. Whether Riosegward will work or not, we do not know. There are no trials except for certain patients with pulmonary hypertension and heart failure where there have been some beneficial effects shown. The other drug which has been shown to be beneficial is the omecamtiv, and again, we do not know the significance of the benefits when added to all the other drugs pooled together. Again, drug is not available with us. Now, when we talk of heart failure, I think we should remember that heart failure and ejection fraction move from one end to the other. For example, you may start with heart failure with reduced ejection fraction, and you can rapidly improve if there's a peripartum tachycardia-induced cardiomyopathy, hyperthyroidism. There'll be a significant quick improvement from reduced ejection fraction to mid-range and preserved ejection fraction. Similarly, a patient with preserved ejection fraction can deteriorate because of ischemia or hypertension or whatever reason. Again, drugs will move the patient from reduced heart failure to preserved heart failure. So therefore, the heart failure with mid-range ejection fraction also is of importance in understanding these mechanisms. Of course, now we have this important terminology called heart failure with recovered ejection fraction. And as you can see from here, a patient with heart failure can then improve and become fully recovered. He can partially recover, or he may not recover at all. So the working definition of heart failure with recovered ejection fraction is that you should have a documented LVEF less than 40%, a 10% absolute improvement, and a second measurement where the LVEF was more than 40%. It's important to remember that in this mid-range ejection fraction, there are many drugs which are beneficial. If you go back even to beta blockers, you can see that even when your ejection fraction is 40% to 49%, you have this significant benefits in cardiovascular death, cardiovascular hospitalization. So clearly beta blockers are also useful, particularly when sinus rhythm is present. If we look at the CHARM trial with candesartan, once again, you can see that in the mid-range, there is a significant benefit in terms of cardiovascular death, heart failure, hospitalization, etc. And of course, we know from the Paragon heart failure trial with ARNI that though there was no overall benefit, there were patients with the mid-range ejection fraction who actually did benefit. So I think it's important to keep this group of patients in mind. They're a moving target. They may improve, they may worsen, but clearly these drugs would benefit these patients, and the patient should not be given the benefit of these drugs. Again, of course, as I mentioned, heart failure is a full spectrum, and you will come to a point where it becomes non-reversible. And how do you treat these patients who come to the very end of their heart failure? Now, the LIFE trial actually looked at that, and they used ARNI in patients with end-stage heart failure. And they found that these patients had no improvement of their NT-proBNP, And in fact, cardiovascular death and heart failure hospitalization was no better, and if anything was worse with ARNI compared to valsartan. So it's important to remember two things from this. One is, do not allow your patients to reach the end stage of heart failure. Treat them much before with proper guided and mediated treatment. And when heart failure reaches end stage, then use these drugs with care, because at the end stage of heart failure, certain amount of sympathetic stimulation, task stimulation is required. And if you block that off, obviously the patient will get worse. So clearly these points need to be kept in mind. So overall, this is a beautiful slide which shows all the possible mechanisms that we have of treating heart failure with reduced ejection fraction. I've not covered everything because of the shortage of time. Please do remember intravenous iron, correction of heart rate with ivabradine. These are important. And of course, devices such as CRT. If the patient has got atrial fibrillation, of course, very important to remember NOACs. The most recent data from the European Society of Cardiology heart failure just a few months ago suggested that we should tailor these patients' treatment individually. So they came up with this sort of a diagram. As you can see in the center are the pillars: SGLT2, beta blockers, ARNI, MRAs, and of course diuretics. And then there are 4 other subgroups: whether blood pressure is low or not, whether the patient has atrial fibrillation, whether the patient has CKD, and whether the patient's heart rate is low or fast. And accordingly, as per this profile, you can individualize your treatment. Again, you must remember that CKD is a varying target. As the patient ages, as heart failure gets worse or better, the creatinine clearance will fluctuate, and you need to adjust your therapy accordingly. Having said all that and showed all this data, the fact remembers that even the most recent trial, called the CAPTURE cross-sectional study, showed that though large number of patients have cardiovascular disease with or without diabetes, actually only 2 out of 10 people who would benefit from these drugs do not actually get these drugs. So it's such a pity that we have now so many drugs available for the treatment of heart failure, but somehow our inertia for some reason prevents us from giving the maximum benefit to our patients. So thank you very much, friends. Thank you very much for your patience.
Thank you, Jimmy. Wonderful as always, very precise and to the point, and a great insight into the guideline determined management of heart failure with reduced ejection fraction. So we have 2 panelists today, Sadanand and Nazir. Yeah.
See about the Vericiguat and this omecamtiv mecarbil. These trials, see most of the trials, whatever heart failure trials we talked of, in class 4, there were less than 1% of the patients. While these new trials, there were sicker patients who were having very poor ejection fraction and high BNP. So I think the molecule which is going to Vericiguat is going to be useful in seriously ill patients, particularly class 4 patients. And the dosage becomes simple, 2.5, 5, and 10. I think the only problem is what will be the cost of this molecule. Now, if you go into that Victoria trial, what it showed was relative risk reduction was somewhere around 10%, but absolute risk reduction was 4. And the number needed to treat to have a benefit was just 24 or so. So this molecule has got a future. One more point I wanted to mention about ivabradine. The ivabradine molecule is misused nowadays. People are using it even for patients with anxiety, neurosis, and tachycardia. If you know the Signify trial which recruited almost 19,000 patients, it did not benefit. So this molecule is to be used in patients with heart failure with reduced ejection fraction less than 35 only, not for any other indication. Even the Beautiful trial did not show. In fact, Signify trial showed there was increased tendency for mortality with this molecule. So these were some of my comments.
Jimmy,
okay, yeah,
outstanding talk as usual. Few things, let us come to the basic now. When we talk about the RNA, we should be stopping A's and ARB at all. Like last what slide you showed, like your precise individualized approach where even the A's, ARB, RNA is mentioned. Personally, I think, probably the RNA is the only way forward, like even in a stable heart failure, etc. What is your comment about it?
Personally, I cannot think of any reason why we should continue with an ACE inhibitor or an ARB. More so because in India we use the wrong ARB. We often use telmisartan where there's no trial with telmisartan. So I think ARB certainly I have no role to play, especially if used wrongly. I mean, the very first trial was a trial of enalapril versus Arni, which showed Arni was better. Now, when you have a drug which is better than what you're using it, I see no reason why to use the original drug. I mean, initially I could understand the first guideline suggesting, okay, patients on ACE inhibitors continue if their symptoms change over. But I think now guidelines are also moving to the fact that we do not necessarily need to start an ACE inhibitor and wait for the patient to worsen. Straight away start Arni as the first RAS blocker of choice. I think there's virtually no doubt, and I'm sure all of us do that anyway.
That's the point.
Even American guidelines also mention Arni as the first choice, unless cost is the constraint. One person cannot afford Arni.
No, that is the point I wanted to drive home, Jimmy. That is one. Now coming to this, 4 weeks, four drug, and then our McMurray saying the first one beta blocker with the GLT2 inhibitor. Any particular beta blocker? Because again, if you talk about the BP lowering, you prefer bisoprolol in that stage, or is it any other beta blocker? What is your choice in here? Because you mentioned 4 weeks, 4 drug, that is a little difficult area,
I think I personally don't like the way McMurray suggested beta blockers and SGLT to start and then start Arni after a week, etc. For a number of reasons. One is that you are never sure the patient is going to come back to you after a month, after a week. The patient will end up to you after 6 weeks or 8 weeks for all you know, and you miss the whole vulnerable period. So I feel it is better to start all the drugs while the patient's in the hospital, and then you can escalate them when they come and see you. Secondly, as a cardiologist and with far more experience of Arni than with SGLT2, and the fact that we see so much improvement in ejection fraction with Arni, I think Arni is a drug which I must use in a patient with heart failure. So I feel very unhappy if I don't have a patient with heart failure on Arni. Yes, of course, I will add SGLT2, and it's easier to add SGLT2 later because it doesn't produce hypotension, it doesn't produce hyperkalemia. I would rather use a drug which can have more problems like Arni while the patient's in the hospital. So I can watch the potassium for a day or two. I can see the patient's blood pressure. So when the patient goes home, I know that there won't be many problems. And then I could add SGLT2 either at the time of hospitalization or soon after that. And of course, we can add MRIs because we also know that when you use SGLT2 and MRIs together, the hyperkalemia is less. So clearly, there is an advantage of adding SGLT2 in terms of preventing hyperkalemia with the addition of MRI. So I would think that there is nothing wrong in using all the 4 drugs in small doses and then gradually escalating them as and when the patient turns up in the OPD.
Jimmy, there are 2 questions. Sada, 2 questions on the chat box.
1 minute, Ajit. Just to tell Jimmy, once the recovery occurs, how long really we have to continue? Because how is your clinical experience?
I think my clinical experience plus other data which is coming out in literature clearly shows that if you improve your ejection fraction from reduced to say mid-range or recovered, please do not stop the drugs for 2 reasons. One is the patient starts deteriorating again. You may well think that if the patient deteriorates, you'll restart the drugs, but there have been instances where the patient does not improve. So the patient may remain in heart failure with reduced ejection fraction because you stop the drugs and the improvement has now become less. So please do not stop the drugs. Yes, you may make minor adjustments depending on the patient's condition. Of course, there may be a few situations like an acute viral myocarditis where you treated the patient, the viral myocarditis settled down, and such a patient, you may think of reducing the drugs. But I think postpartum cardiomyopathies, chronic heart failure cardiomyopathies, I would very much be hesitant in reducing or stopping drugs.
Or heart failure because of hypertension?
Again, because of hypertension, I mean, there are a few instances where I think you'll have to play it by the ear. And I mean, I would use Vimad as an antihypertensive also in a patient with reduced ejection fraction. So stopping Vimad and putting them on telmisartan or olmesartan. So why not continue?
Last question, Jimmy. One is, what is your take on the new data which is coming up of the SGLT1 inhibitors?
Of course, the SGLT1 inhibitors are extremely useful. We saw the latest trial, Solace, which clearly showed that it was beneficial, in fact, also in preserved heart function. But I think Dr. Ponde will touch upon that, I'm sure. So I think the SGLT1 and 2 inhibitors are probably maybe better and might actually replace the older SGLT. So in spite of all the talk of DAPA and EMPA, we might completely replace them. So that is a possibility.
Thank you.
But
I think,
okay.
I think Sada, we are overshooting the time. We'll go on to the next talk.
Yeah, thanks.
And the talk is going to be about guideline determined medical therapy of heart failure with preserved ejection fraction. And we have Dr. Ponde as the speaker and Dr. Brian Pinto and Manoj Mashru as the panelist. Yeah, Ponde.
Good evening. I'm happy to be here today, and I'm going to speak on new avenues of treatment in heart failure with preserved ejection fraction. The universal definition of heart failure has relied on ejection fraction for several decades. Heart failure with reduced ejection fraction when the EF is less than 40%, and heart failure with preserved ejection fraction when the EF is more than 50%. And in between, you have that new entity, heart failure with mid-range ejection fraction. However, soon you will realize that these definitions have been more or less arbitrary and need serious revision. The prevalence of HEPF is steadily increasing, and almost 50% of patients worldwide with heart failure have preserved ejection fraction. Are the clinical outcomes in HEPF and HEPREF are different? No, not at all. In observational studies, the 10-year mortality in these two syndromes is nearly and virtually the same. The H2F PEF score helps to distinguish HEPF from non-cardiac causes of dyspnea, because as we all know, it is very easy to diagnose HEPREF. All that you need is a symptomatic patient, clinical signs of heart failure, and that magical figure of ejection fraction of less than 40%. Whereas when heart failure with preserved ejection fraction presents, merely having symptoms and signs of heart failure and a normal ejection fraction is not enough. So here we have such scoring systems. If you look at this score, obesity gets a score of 2, atrial fibrillation gets a score of 3, and systemic hypertension, pulmonary hypertension, age, and high filling pressure each get a score of 1. So when you have a total score of 1 or less, heart HEPF is unlikely. When you have a score of 6 or more, HEPF is almost certain. Between the two, you have a gray zone where you need some more data. The ESC HFA HEPF diagnostic algorithm also tells you, do your initial workup, which should constitute of the clinical signs and symptoms, ECG, standard echo, BNP, and probably a 6-minute walk test. If with this all, if you suspect that HEPF is very, very likely, you go for diagnostic workup. That is a step E. In this workup, functional criteria of E by E prime, morphological criteria like LA volume, and biomarker criteria in terms of BNP get either a major point in terms of quantum, or they are less deranged than a minor point. And one major criteria gets 2 points, one minor criteria gets 1 point. And if your total or cumulative more than 4 points, it is diagnostic of HEPF. If you fall into the gray zone, then probably you need to do advanced workup, and that is in terms of a stress echo or a stress invasive hemodynamic monitoring, which will calculate pulmonary capillary wedge pressure increment on exercise as compared to that in rest as a diagnostic hallmark of HEPF. Well, are natriuretic peptides always elevated in HEPF? No, not really. To add to the confusion and mystery, natriuretic peptides are normal in up to 30% of patients with HEPF, particularly in patients who are obese, who have metabolic syndrome, who have purely exertional symptoms, or those who are anemic. The important and the fundamental difference between HEPREP and HEPF has been the fact that HEPREP starts at the level of myocardium and then goes elsewhere. And you have poor renal perfusion, poor organ perfusion, etc., etc. Versus heart failure with preserved EF starts elsewhere, everywhere, and ends at the level of heart. So you have pulmonary abnormalities such as chest wall restriction, reduced vital capacity, pulmonary arterial hypertension, and OSA. Then in liver, you can have non-alcoholic fatty liver disease and generalized inflammatory state. In renal, you have direct toxic effects of perinephric fat on glomerulomegaly and glomerular dysfunction. And you have visceral adiposity producing inflammatory cytokines. In the muscle, you have increased adipose infiltration and decreased diffusive O2 transportation. All this finally lead to the cardiac abnormalities producing the syndrome of HEPF. Well, if you look at the mortality in HEPREP, almost 2/3 of mortality in HEPREP is because of cardiovascular causes, as against in HEPPEP, 50% of mortality is because of non-cardiovascular causes. And that is exactly why a drug which is acting at the level of myocardium and myocardium alone is unlikely to succeed in the battle against HEPPEF. If you look at the prior failed outcome trials in HEPPEF, such as CHARM Preserved with candacertan, I Preserved with irbesartan, PEP-CHF with perindopril, and TOPCAT with spironolactone, they all failed to meet their primary endpoint. And that is because the populations enrolled were diverse. Alternative causes of dyspnea were not carefully or extremely carefully excluded, and the follow-ups were not very rigorous. However, in the TOPCAT, spironolactone did reduce heart failure hospitalizations, and this effect was independent of its diuretic effect. That was very clear. And therefore, if you look at the management pillars of HEPPEP until 2016, it was all focused upon symptomatic treatment with diuretics, treatment of comorbidities such as hypertension, control of rate in atrial fibrillation, treatment of other comorbidities such as OSA and obesity, treatment of ischemia, and of course, spironolactone. And if you look at the guidelines until 2016, not much was there except primarily diuretics and ARBs, which may be considered to decrease hospitalizations level of indication 2B. And then we got the moment of truth. This one study, a large study from Europe, routinely reported ejection fraction and mortality in clinical practice of close to 40,000 patients. They saw that the nadir of mortality in ejection fraction is close to when the ejection fraction is 60 to 65%. Above that and below that, there is an increase in mortality. So there is really a J-shaped curve for mortality with ejection fraction. And the NEDA database, the National Echocardiography Database of Australia, having almost 5 lakh men and women echocardiographic ejection fraction, showed that again, the nadir lies at an ejection fraction of around 65% in men and 69% in women. And in women, at all regions of ejection fraction below that, the mortality is higher than that in men. So this gender heterogeneity is also a very important factor to be considered when you are talking about HEPPEP. And there were more failures. Soluble guanylate cyclase stimulators, PDE5 nitrate and nitrites, they all failed to show mortality or hospitalization benefits in heart failure. So they will not be talked about henceforth in HEPPEP scenario. Then came ARNI, and the Paramount trial showed significant improvement in several soft domains such as NT-proBNP, improvement in left atrial size, and improvement in NYHA class. And that gave birth to the Paragon heart failure trial, which enrolled patients more than 50 years old, ejection fraction 45% and above, class 2 to class 4 heart failure, and elevated natriuretic peptides 2, ARNI, and the comparator arm was that of valsartan. And in this trial, the heart failure hospitalizations reduced, but not statistically significantly, and cardiovascular death, no significant difference at all. But there was a sexual heterogeneity. The women tended to benefit significantly better than men. And if you look at ejection fraction of less than 57% benefited significantly more than the ejection fraction more than 57%. So the mid-range ejection fraction, 45 to 57, did benefit from ARNI as far as heart failure hospitalizations were concerned. So the Paragon heart failure, when you look at ejection fraction, less than 50, certain benefit, 50 to 57%, definite benefit, and up to 63%, there was a trend towards benefit. However, statistically non-significant. Above that, there was no significant benefit. And when you look at prior hospitalizations, if the patient earlier, the latest the patient had hospitalization, the more was the benefit. The remotest hospitalization had no benefit or less benefit, and no hospitalization had virtually no benefit. When you look at the older trials and compare the benefit in Paragon versus Paradigm, Charm and Topcat, in these two trials also, the mid-range ejection fraction patients tended to benefit with candacertan and spironolactone respectively. And in Paradigm and Paragon, when you compare, the magnitude of benefit in Paragon mid-range ejection fraction was virtually the same as that of Paradigm low-range ejection fraction. What does this mean? That we can certainly now treat mid-range EF, and it is time to redefine HEPREF. In Dr. John McMurray's opinion, probably HEPREF will be reclassified as 55% and below, or 57% and below to be precise. HEPREF, anything above that will be HEPPEF. We all know that HEPPEF pathophysiology has this multiple facets: diastolic dysfunction, impaired vasodilatation, impaired systolic reserve in terms of impaired GLS, chronotropic incompetence, renal dysfunction, lack of neurohormonal activation, impaired ventriculovascular coupling, subtle resting contractile dysfunction, and systemic and pulmonary vascular dysfunction. SGLT2 inhibitors have myriads of actions: reduction of arterial stiffness, reduction of uric acid, reduction of oxidative stress, persistent low-grade ketonemia, exposing the myocardium for alternative fuel, natriuresis and diuresis, decrease in sympathetic activity, and decrease in visceral adiposity. And therefore, SGLT2 inhibitors form an attractive option for treatment of HEPPEF. And pooled data from soloist and scored trials with sotagliflozin has shown benefit in HEPPEF in type 2 diabetes at all ranges of ejection fraction, even when it crosses above 50%. And thankfully, men and women tended to benefit equally with this novel SGLT1+2 inhibitor, sotagliflozin. Then came Emperor Preserved, empagliflozin versus placebo in HEPPEF. 6,000 patients, mean age 72, 50% diabetics and 50% non-diabetics, 50% at CKD, mean LVF 45 to almost 63%, mean NT-proBNP of 974, almost all on guideline recommended medical therapy. And top-line results have shown that this molecule has reached its primary endpoint in HEPPEF. The details are yet to come to us, and we will await them. Fine Arts trial, finerenone, which is a non-steroidal MRA in HEPPEF, is ongoing and will be completed by early 2022. Results will be available by late 2022. Reduced LAF HF trial, where a interatrial septal device which allows a controlled shunt between left atrium and right atrium to decompress the left atrium in patients with HEPPEF is again ongoing, and the results will become available to us by 2023 early part to tell us about the use of this device in patients with HEPPEF. So my conclusions and final thoughts, my friends: the phase and understanding on HEPPEF is changing. Probability scores must be used to aid diagnosis and to avoid misdiagnosis of HEPPEF. So please use these scores. Patients with mildly reduced EF, that is mid-range ejection fraction, may respond to therapies that benefit those with more severely reduced EF, that is HEPREF. So please remember, HEPREF and HEP mid-range, they respond almost identically to therapies that are established now in patients with HEPREF. SGLT2 inhibitors, thanks to their multifaceted actions, are likely to come in guidelines in near future. We have Emperor, we have Soloist, and we have Deliver. And new forms, non-steroidal mineralocorticoid receptor antagonists are on horizon for HEPPEF. And finally, devices such as interatrial septal device may be an option for treatment of select patients with HEPPEF. And as I always say, HEPPEF though our understanding is becoming better, we are able to understand now multiple facets of HepPep, multiple phenotypes of HepPep. Still, this will remain an enigma to solve on a therapeutic domain for some time to come. Thank you for your patient attention.
Thank you. Thank you, Shekhar.
Yes,
I think
thank you.
wonderful, wonderful talk as usual. You have given a precise and a great concept as far as treatment and the overview of PEF. So we have two of the panelists today, Dr. Brian Pinto and Dr. Manoj Mashru. Are they there? Manoj? Manoj? Manoj, are you there, or Brian?
Now in India,
Is Brian around, or? I don't see anybody. Okay, there is a question from Shekhar. There is one question. Any role of GLP-1 analogs, especially in HFpEF patients with metabolic syndrome?
Yeah, there is a data now coming up from the Pioneer 5 and the Pioneer 7 trials on semaglutide, oral semaglutide, and these patients have really shown a decrease in heart failure hospitalizations across the range of ejection fraction, as low as 30% to as high as almost 55%. So there will be some data, but the number of patients enrolled in this trial of previous history of heart failure were pretty small. So I think it will be premature for me to interpret that these drugs will help. But I think GLP-1 receptor agonists have some promise there. Yes, definitely.
Okay. So Shekhar, one question. Once you have decongested these patients who come with failure in HFpEF patients, what would be your first drug to be used? Is it going to be ERNI, or is it going to be an SGLT2 inhibitor?
I would still say that if the patient is of normal weight, which is very unlikely actually in HepPEF, if the patient is on the overweight side and obese side, I think SGLT2 inhibitors should precede or go together with ARNI if the blood pressure permits. And this is because the SGLT2 inhibitors have a multi-pronged approach to address multiple myriads of abnormalities in HepPEF, including vascular inflammation, including the adiponectin levels, including the visceral reduction of visceral fat, and causing osmotic diuresis, which predominantly affects the interstitium rather than intravascular compartment. That is extremely important in HepPEF. And Nitin's case was fantastic example of how SGLT2 inhibitors could have benefited that patient. So I think these patients are relatively diuretic resistant, including to loop diuretics, and SGLT2 inhibitors will be a great drug to give. However, remember that in Paragon heart failure, patients with ejection fraction from 40 to 57%, the magnitude of benefit for heart failure hospitalizations was virtually the same as that in patients with HepRep in paradigm heart failure. So I think both these drugs will soon come in guidelines, very soon come in guidelines with for heart failure with preserved ejection fraction.
So Shekhar, is there a possibility that if you have these patients of HepPEF, will use both the drugs, or you would prefer only use of one of the two drugs?
As we do for HepRep, by 4 to 6 weeks, get as many of them on the guy on the board. So I think in 6 weeks time, I will probably have both of them on board if you have those kind of mid-range ejection fractions, like 45% to 60% in men and 45% to as high as 65% in women.
Yeah, the question question here is because how are you going to follow up these patients, and how long are you going to continue with the treatment modalities?
See, the NEDA database says that for obese patients with HepPEF, the treatment could be virtually lifetime, for the simple reason that even if they lose weight, their left atrial volumes remain high. In Nitin's case, beautifully pointed out that the left atrial strains remain persistently low, and their E by E prime ratios never ever tend to normalize. They never normalize. As against that, if you have mid-range ejection fraction, 45 to 57%, and the patient is not overweight, lean, and these are typically the East Indian East Asian variant of HepPep who are BNP deficient. Caroline Lamb's beautiful article in JACC just around 3 months ago has shown this new phenotype, East Asian phenotype, BNP deficient, lean phenotype of HepPep. They will benefit with HepRep therapies for almost lifetime.
Any role of ivabradine as far as treatment of HepPep is concerned?
Not actually, but earlier articles had suggested, that to maintain the resting heart rate of HepPep patients close to 70, to allow longer diastole and better left atrial emptying. So, but there is no data to support. I mean, there is no real hard data to support that. Dr. Mashri, you wanted to say something?
Yeah, Shekhar, excellent talk. I liked your last sentence the most. The diagnosis and the management is still enigmatic. And for example, if you have a patient who's 55, 60 years old, hypertensive, obese, complaining of exertional dyspnea, echo showing dilated LA, so he's almost there. We do the pro-BNPs with patient exertional dyspnea, but the pro-BNPs are still normal. Yes. The management of diagnosis to call it a heart HFpEF or the management in such a case, it continues to be enigmatic.
Sure.
So how would you manage such a patient? I mean, you've shown that you can do the right heart catheterization. The echo shows mild pulmonary hypertension.
Yeah, I think the earliest to do is just to do a quick stress echo, make the patient walk in the corridor for 4 to 6 minutes, something like a 6-minute walk test. Take that performance, let them lie down on the table quickly and see the resting E by E prime versus exertion, post-exercise E by E prime, resting PA pressure versus post-exercise PA pressure, and that will virtually clinch the issue. The second thing which Dr. Burkule said very properly, and which we have been using now, after Dr. Burkule's inspiration, of course, is the left atrial strain. And reduction in left atrial reservoir strain is another hallmark of HFpEF, absolute hallmark of HFpEF. And recently there was a young boy who was sent to me, exertional dyspnea, pulmonary function tests have been done. He was not really overweight, he was hardly 70 kgs. And we did left atrial strain, it was 22. And E by E prime at rest was 12, which increased to 27 on a 6-minute walk test. A clearly HFpEF patient. And then we did a cardiac MRI, and cardiac MRI showed that there was a lot of increased extracellular volume, which we never thought on echo at all. And it turned out to be amyloid at the end. So you exercise echo is, I think, really very important and underused modality in picking up these patients with HFpEF. Thank you.
Yeah, thank you. Thank you, Shekhar. Wonderful insight you have given us about the HFpEF patients and how to manage them. So we move on to the next topic of today, and that is about right ventricle in heart failure, a thing which we usually do not give so much of importance. And Dr. Milind Phadke is going to give us an insight into that. And we have Dr. Shantanu Deshpande and Darshan Jhala as the panelist. Can we move on, please?
Good evening. I'll start right away because my time is limited. If you examine the anatomy of the right ventricle, it is rather complex. The RV is coarsely trabeculated and it has 3 components: an inlet, an apex, and an outlet. In cross-section, the RV is crescentic and it is relatively thin-walled. It has a large tricuspid valve, which is septophilic and apically placed. The fiber arrangement of the RV also differs from the LV. The RV has 2 layers of fibers: an outer layer which is continuous to the LV layer and an inner one which is oriented towards the apex. So unlike the LV, the RV does not have significant translational or rotational movement or torsion. The contraction of the RV is described as being peristaltic in nature. Most of the contraction of the RV is longitudinal. So this movement draws the tricuspid valve towards the apex. The left ventricle from the IVS contributes to about 20 to 40% of the RV contraction by placing traction on the RV free wall. Since the RV faces the highly compliant pulmonary circulation, it achieves the same stroke volume as the LV, but at a much lower energy expenditure with 1/4 the stroke work of the left ventricle. The RV is very sensitive to afterload. As this graph shows, even a small increase in afterload can cause a precipitous fall in the RV output as compared to the LV, which relatively tolerates increase in the afterload better. On the other hand, the RV tolerates volumes much better. The RV and the LV are also coupled in various ways by the shared interventricular septum, by a common pericardial space, by the continuous layer of fibers, and by the fact that the RV is inserted into the LV and wraps circularly around it. This gives rise to the phenomenon of ventricular interdependence, which means that change in the size, shape, and pressure volume loop of one ventricle causes reciprocal changes in the other ventricle as well. The ventricular interdependence is of two types: systolic, which is through the IVS, and diastolic, which is through the fact that they share a pericardial space. So when the RV volume increases, the interventricular septum shifts towards the left, the LV becomes T-shaped, the LV preload decreases, and its stroke volume output can go down. The RV has a dual blood supply, and the three important characteristics are that coronary flow occurs throughout the cardiac cycle. The RV has lower oxygen extraction and therefore a higher oxygen extraction reserve, and there is a potential for acute collaterals to develop from septal branches, as well as there is a separate coronal artery. So there is a good anatomical reserve when there is acute occlusion of the right coronary artery. So therefore, even when the RV undergoes infarction, the changes in the wall motion are often not irreversible, and in time the RV does recover because of the three factors mentioned earlier. The ischemic ventricle is of course very preload sensitive. So one of the most important parts of the therapy is infusing adequate volume to ensure that the preload to the RV is maintained and to avoid venodilators such as nitrates. Then in systemic hypotension or in conditions that increase the RV transmural pressure, like severe RV volume or pressure overload, the coronary perfusion to the RV goes down. The RV coronary perfusion is very, very sensitive to hypotension, much more sensitive than the LV. The RV pressure curve is triangular in shape. If the pressure level is lower than the LV, it has a quick rise and a quick fall, and it has what is known as a hangout interval. That is, at the end of systole, when the ventricular arterial pressure gradient becomes negative, forward flow across the pulmonary valve still continues for a short duration because of the highly compliant pulmonary circulation. So these are the factors that can affect RV function, and most of the etiologies of RV failure affect one or more of these factors when they cause RV dysfunction. The commonest cause of an increased afterload is pulmonary hypertension, which could be PAH, left heart disease, CTPH, or many other causes. Systemic factors like obesity, hyperventilation, and acidosis and hypoxia should also be considered, as also some forms of congenital heart disease. RV contractility may be impaired by ischemia, infarction, or muscle disorders, or rarely systemic inflammation. Volume may affect the preload, both hypo as well as hypovolemia. Cardiac tamponade has its own unique pathophysiology, and as described before, because of the LV-RV relation, LV forward failure can also affect RV function. I've already talked about interdependence, and rhythm is also important for the RV. A loss of AV synchrony or loss of effective atrial contraction or a very, very rapid heart rate may impede RV filling during diastole and further cause RV dysfunction. So this is just a summary of how all the factors which affect RV pathophysiology are interrelated, including TR, RV dilatation, RV afterload. So most of them are interdependent and interact with each other, so that even if there is one principal mechanism of RV failure to start with, it often gives rise to other mechanisms, and the whole thing can spiral out of control and cause irreversible RV failure. Tricuspid regurgitation can cause RV volume overload and further worsen TR. So TR can beget TR, and this can also be responsible for deteriorating RV function. The common causes of RV failure occurring acutely are pulmonary embolism and infarction. Pulmonary embolism typically when more than 50% of the pulmonary vascular bed is occluded. Another interesting situation in which RV failure can occur is immediately following implantation of an LVAD. So due to multiple mechanisms as stated here, in up to 20% of patients, acute RVF may develop post-LVAD implantation, and this needs to be recognized and treated. Similarly, RV failure can occur post-cardiac surgery and transplantation as well. Clinically, patients present with signs of peripheral hypoperfusion, hypotension, sometimes cyanosis due to opening up of a PFO and right to left shunting. Pre-syncope and syncope can occur in some situations. In clinical examination, a raised JVP is often characteristic, and the TR murmur may be appreciated. And the combination of raised JVP, clear lung fields, and shock is often considered characteristic of either pulmonary embolism or RV infarction. When we manage a patient, it's important to have a focused clinical examination, look for the etiology and precipitating causes, get the basic lab values and ECG and X-ray, and most importantly, bedside 2D echocardiography and imaging. After that, then we would like to optimize the volume status, restore perfusion pressure, and if required, improve myocardial contractility and move on to other advanced options. Assessment of the volume status is important. In addition to clinical features, we also should look at echo, the vena cava on echo, the IVC, and lung ultrasound. We should not be very, very aggressive in infusing volume in patients who are well hydrated or who are slightly hypovolemic, as this can cause RV volume overload and septal shift towards the left side. It's also important to recognize systemic factors which can exacerbate RV failure and correct them wherever possible. So when we optimize volume, we should avoid volume overload. And in a patient who has acute and chronic heart failure and is congested, we should give an adequate dose of loop diuretics and measure the diuretic response to urinary output and urinary sodium. Diuretic resistance can be an issue, and there are several measures which can be used to reverse diuretic resistance. The next step is use of agents which increase the systemic blood pressure, because maintaining a systemic blood pressure that is normal is quite important to prevent further deterioration of RV function. Either epinephrine or vasopressin can be used. Vasopressin causes less arrhythmias and probably causes less increase in the PVR. Although the MAP may be targeted at 65 millimeters mercury, in a grossly congested patient, it may not always be a reliable marker of organ perfusion. If restoration of perfusion does not work, then one may have to use inotropes, where dobutamine, milrinone, and levosimendan are probably the agents of choice. Milrinone causes less tachycardia and reduces the PVR, but it may cause more hypotension and may have issues in patients with renal dysfunction. Simultaneously, one must also consider treating the specific cause, for example, revascularization in patients with ischemia, lysis, either systemic or catheter directed for PTE, long-term oxygen therapy for lung diseases, and IV prostaglandin infusions in patients with severe PAH and heart failure. Sometimes IV prostaglandin infusions can cause hypotension, then inhaled agents including nitric oxide may be used. And some patients may have to go on and get mechanical circulatory support if the response is not good and if there is severe shock which is unresponsive to the traditional measures. We're all aware of the signs and symptoms of chronic RV failure. The JVP needs a special mention because it has a lot of prognostic significance. Various studies, including analysis of the SOL registry, have shown that it correlates well with cardiac mortality and hospitalizations. And not only does it correlate well with the RA pressures, but also with the PCWP. Similarly, the Kussmaul sign is an indicator of reduced diastolic compliance of the RV. So when the patient inspires, the RV cannot handle this increased venous return and the JVP rises. It is considered quite indicative of either constrictive physiology or RV infarction, but it also has prognostic value in heart failure. So this is a good article from JCC Imaging. It tells us how the clinical examination can be used both to assess an elevated PCWP as well as an elevated RA pressures, and then classify patients based on whether the right heart, left heart, or both filling pressures are raised or filling pressures are completely normal. This is an important sign. Sometimes the RA by PCWP ratio is elevated. That is, there is a disproportionate right heart pressure elevation as filling pressure elevation as compared to the PCWP. This pattern has been shown to be associated with worse outcomes and with bad renal function, something to look at when a congested patient on diuretic starts developing renal dysfunction. Not much to say about echo because we have had two great talks on echo and MRI, but these are the specific things that one looks for. Some of the limitations of the sign should be known. TAPSE, for example, doesn't give any idea about the it gives an idea only about the longitudinal function. The fractional area change doesn't assess the RVOT. The S dash is angle dependent. The two modalities which are increasingly now being used and which correlate very well with MRI findings are free wall longitudinal strain of the RV and use of 3D ejection fraction to accurately identify RV function. So this is just how the RV looks on 3D. And because there are no volumetric assumptions, 3D is considered the gold standard and almost comparable to MRI for volumes and function. On catheterization, simple measures like the RA or the RA-PCWP ratio are quite useful and have a prognostic predictability in specific situations. The PAPI or the PAPI is used also again to predict right heart failure in acute MI or after LVAD. So these are some simple indicators which can be used even in routine cardiac catheterization, and some of the other indicators require measurement of the stroke volume and cardiac output. So when you're doing a right heart catheterization, it's useful to measure these indicators. The commonest cause of right heart failure is left heart failure, and the commonest mechanism is pulmonary hypertension. Now, left heart failure of various etiologies can cause RV dysfunction, and PH in left heart failure is classified as being post-capillary or combined pre-capillary and post-capillary. Post-capillary PH means that it is exclusively due to raised left heart filling pressures or raised LA pressures of PCWP. Combined means that there is also pre-capillary component, that is, there is some obliterative or constrictive change in the pulmonary arterioles as well. So how do you make this diagnosis? It is made on cardiac catheterization by measuring the PCWP and the mean or diastolic pulmonary artery pressures. The difference between the two gives respectively the transpulmonary gradient or the diastolic pulmonary gradient. And that can classify PH as pre-capillary, post-capillary, isolated or combined. The older terms like passive, reactive, obliterative are no longer used. Now, HFpEF deserves a special mention because it's quite common, and RV failure is common in HFpEF, though it may be mild to begin with. There is a group of patients can present predominantly with RV failure. So this RV failure predominant phenotype of HFpEF is well recognized for almost 7 or 8 years now, and this should be looked for. And HFpEF is a major, RV failure is a major marker of mortality and morbidity in patients with HFpEF. And the diagnosis is made now as per guidelines by echocardiographic or MRI criteria in patients who have pre-existing HFpEF. The main mechanism of RV dysfunction in HFpEF is PH, but other associated comorbidities and risk factors like AF or hypertension, diabetes, COPD, all of them can cause adverse remodeling of the RV independent of pH. TTR amyloidosis also is being increasingly recognized as a cause of HFpEF and RV dysfunction in older individuals. When you're diagnosing HFpEF in the cardiac cath lab, it's important that not only the baseline PCWP, but also the PCWP with exercise or volume challenge be measured if the baseline is normal. Because in some patients, PCWP may only rise with exercise or volume challenge. If you don't do this, you may miss out on these patients and wrongly diagnose them as having normal left heart filling pressures. Treatment is frustrating. Conventional measures, of course, are used, diuretic fluid restriction, but the usual medicines for heart failure don't work well in HFpEF or in RVF in HFpEF. Even targeted pH therapy, the vasodilators don't work very well. In fact, the endothelial antagonists should not be used because they increase the PCWP. And even PDEF inhibitors are found to be equivocal to negative. Maybe in a minority of patients in whom we have demonstrated that there is combined pre and post capillary pH, we can use these agents. But the message is that both in HFpEF and in HFrEF, we should not just empirically use phosphodiesterase 5 inhibitors or any other pulmonary vasodilator. They don't work and they can be counterproductive. The only real indication is patients with pre-capillary pH, that is PAH, and in some patients with thromboembolic pH. Other than that, pulmonary vasodilators should not be used. In cor pulmonale, what starts off as an adaptive remodeling of the RV in response to increasing PA pressures finally becomes maladaptive and the RV fails. TR again begets TR and worsens the clinical situation. The diagnosis is usually made on echo. While some of the echo parameters may not be always reliable, newer modalities like strain and 3D assessment of volumes and RV function are again playing a very important role. And the presence of RV dysfunction in patients with cor pulmonale again is of great prognostic value. I've already spoken about pulmonary vasodilators and their role. Final slide is on arrhythmias. It's important to maintain sinus rhythm, and patients, as I've said before, who have arrhythmias which impair RV filling can cause rapid deterioration in RV function. Similarly, LV dysynchrony should also be corrected whenever possible. Thank you. I've tried to do justice to this vast topic. I hope I've managed it in the time span of 15 minutes. Thank you.
Thank you. Thank you, Milind. That was really an exhaustive talk as far as I think the most neglected part, that is the right ventricle, as we usually do it. So we have the two panelists, Shantanu and Darshan Jhala.
Yeah.
Yeah, Shantanu?
Yeah.
Yes.
Very nice talk, Milind. You almost covered from anatomy till management, everything. So, as said previously, RV is the most neglected chamber in a heart failure treatment, but that's most troublesome. It gives most trouble managing these patients. One question for you, Milind. Many times these valvular patients, they get operated for the left disease like mitral disease, but they have a they later on the wall is functioning well, EF is normal, but they have persistent right heart failure and they are very difficult to manage. So the two things is the persistent heart failure. Most of the time they get diuresis, use of diuretics is much higher. And what's the role of digoxin?
No, yeah, per se for right heart failure, digoxin is now recommended, and we have very few options. In fact, beta blockers don't really work well because we don't want too much negative inotropy on the right side of the heart because the preload is important here. And digoxin probably should be used in these patients. And the other important thing in these patients is that a lot of them have residual pH. So even if you operate the left-sided valve, their pulmonary artery pressures don't go down completely. So we are often surprised that the patient has been operated 2 years ago for mitral stenosis or regurgitation and the pulmonary artery pressures are still 60 or 70. So these patients have a significant pre-capillary component. So it's not a bad idea to catheterize these patients and actually demonstrate that they have pre-capillary pH. If they indeed have persistent pH, which is pre-capillary, then one might even consider pulmonary vasodilators in these individuals. So I sometimes feel that cardiac catheterization is underused a little bit in the diagnosis of pH.
Second is a patients with a congenital heart disease with a residual pulmonary regurgitations or like pulmonary regurgitations and tricuspid regurgitations. Now they are a unique problem, and there sometimes the interventions can help to treat pulmonary right heart failure.
Very true, very true. Because we are having now a huge volume of patients who are entering their third or fourth decades post-op repair.
Yeah.
And these patients are presenting in their 30s, 40s or 50s with RV dysfunction. Many of them have had an active lifestyle so far. And we have to pick these patients up early because we should not be hesitant to regularly monitor these patients on MRI, look at their ECGs carefully. And eventually, if the time comes, either on the basis of MRI or clinical criteria, we should not be hesitant about advising pulmonary valve replacement in these individuals because they have still decades more to live and we can make a significant difference to their both longevity and quality of life. Very important. I agree.
Darshan, any inputs from you?
Yeah. Dr. Ajit sir, thank you because I read a very interesting article while preparing for this kind of a thing. So I think I should share my views on this. And that actually refers also to Dr. Shantanu's both the questions. The thing is that Dr. Milind Phadke said that the RV has these muscle fibers which are different. See, the free wall has longitudinal fibers, but they are very thin. And as per that particular article, there is hardly any contribution in terms of longitudinal shortening given by the longitudinal fibers. In fact, the most neglected part of the right ventricle is actually the IVS. And IVS is no longer now considered to be an interventricular septum. It is called a biventricular septum. In fact, the twisting fibers which are present in the IVS are the ones which cause TAPSE. And so the article stresses that in chronic mitral regurgitation, for example, which has been operated for surgery and the RV has failed, the reason is that the ventricle dilated, the left ventricle dilated, and the twisting fibers became circular. And that is why they lost their efficiency. Same thing happens when there is persistent pulmonary regurgitation. The septum bulges into the left ventricle and the anatomy becomes, the fibers become circular. And circular fibers are not as effective as twisting fibers. And that is why one must pay a lot of attention to preserving the septal function whenever any surgery is being done. This has been noticed when the tetralogies were being repaired, and actually free wall incision or RVOT incision does not make a difference. What makes the difference is to preserve the left ventricle in the interventricular septal function. So I think we have to pay more attention to the biventricular septal function, not allow either RV to dilate, LV to dilate, and maintain the ventricular function. And we have seen this in the CRTs also. when the left ventricle and the septum and the left ventricle become synchronous, even if the RV has failed, these people improve. So I think that is one of the most important things I think we should learn from this, that the importance of ventricular septum is not only for the left ventricle, but equally or maybe even better for the right ventricle.
Yeah, up to 40% of the ventricular right ventricular contraction is provided by the interventricular septum through traction. So it's a very important structure.
Yeah, wonderful, wonderful input, Jala. There's a question for you, Milind.
Yeah.
Use of contrast echo in RV dysfunction.
No, I have absolutely no idea.
Okay. And the other question is, trick valve is actually contraindicated in RV dysfunction.
What is
any input? Trick valve? The valves which are used put in the SVC and the IVCs.
Yes, because you may actually add to RV dysfunction. I mean, it's not a valve to be used just across the board. We must very, very carefully evaluate the RV function when we are using these valves. That's very important.
Okay. Wonderful talk, Milind. One last question. We have the settings of RV failure with the left ventricular failure and those settings where there is an isolated right ventricular failure. Any difference as far as biomarkers are concerned in these two categories? And what is the implications of treatment for these patients?
Okay. So isolated RV failure in terms of biomarkers has not been well studied independently. The biomarkers, it is recommended by various working groups and consortia that biomarkers be measured. But as far as I am aware, there are not, I mean, I may be wrong, please correct me, but there are not any specific cutoffs which are different for the right ventricle as compared to the left ventricle, at least guideline based. So I'm open to correction by the panelists. But it is recommended that they be used, and in patients with isolated RV failure who are being followed up, biomarkers are used and should be used both for making a diagnosis and for monitoring therapy. Undoubtedly.
So as far as treatment is concerned for RV failures or RV dysfunction, how do you manage them as far as the investigations are concerned? Is it going to be only harping on echocardiography or is anything else?
So echo, biomarkers and MRI. CMRI probably is the most important thing. Even to detect early subtle RV dysfunction, it's 3D and MRI which are now going to play a role. Because echo, 2D echo for the RV is as good as, it hardly picks up 50% of what we want to know. So we must have good strain imaging, we must have good 3D volumes, and we must have MRI. So to monitor RV dysfunction, I think these are the three most important things. And then, of course, biomarkers, but biomarkers will rise a little late. We want to pick up RV dysfunction much earlier than that.
Okay, thank you. Thank you, Milind. Thank you, Shantanu and Darshan, for your inputs also. We move on to the next one, which is very, very interesting and very important. Working in sync, arrhythmia management and device therapy in heart failure. The talk is going to be by Ameya Udevar, and we have Ashish Nabar and Amit. I can see Amit. He is the panelist for this particular talk. Can we go ahead, please?
Good evening, everyone. First of all, I would like to thank the CSI Mumbai chapter for giving me this opportunity to talk on this topic. The topic assigned to me is working in sync, arrhythmia management and device therapy in heart failure. So as we all know, there is a decreasing survival after heart failure diagnosis. Most of the time you will see once the patient has been diagnosed with heart failure, the survival is dismal and only almost 35 to 40% of the patients survive up to 10 years. And one of the reasons is that we don't use the drugs which should be used. There have been a lot of trials in the last 1 year which have showed impressive results. But if you go to the history of last 30 years, ACE inhibitors and ARBs have been found to have mortality benefit, almost trials dating back to 1990s. Similarly, with beta blockers, Merit, Comet, Cibis, all these trials showed that there's mortality benefit with beta blockers. And yet, even now, we see a lot of heart failure patients who are not prescribed either an ACE inhibitor or an ARB or a beta blocker. This would definitely help in reducing the mortality rate in these patients. Now, coming to one of my patients, admitted 72-year-old lady with mild LV failure, was treated with diuretics. She is a known case of dilated cardiomyopathy with an LV ejection fraction of 25%. Her angiography was done, which showed normal coronaries. This is her ECG. When you see the ECG, the first thing which strikes you is that she has a left bundle branch block pattern. There's a sinus rhythm which is going on with a prolonged PR and lot of ventricular ectopics. So as we all know, a prolonged PR interval is evidence of AV dyssynchrony. Left bundle branch block pattern, because the left bundle is blocked, the right ventricle contracts first, and that's why it is an interventricular dyssynchrony. Not only that, when you have LBVB, you will see that the septal wall contracts first and the lateral wall contracts later. So there's an intraventricular dyssynchrony as well. And multiple VPCs. Now the VPCs are nothing but interventricular dyssynchrony, because you may have a VPC from the LV side and then the LV contracting first, followed by the right ventricle. During a VPC, there is no AV conduction. In fact, you have a VA conduction, and that's why it is evidence of AV dyssynchrony. So how do you maintain synchrony in this patient? Number one, normalize the PR interval, correct the left bundle branch block by bringing in synchrony, reduce or eliminate the ventricular ectopics, and prevent sudden cardiac arrest or VT, prevent atrial fibrillation or flutter so that you maintain the AV synchrony and the atrial kick, and reduce the sinus node rate to reduce the mortality. The first goal, normalize the PR interval. We all know atrioventricular dromotropathy, which is a distinct entity in heart failure with prolonged PR interval. One of the reasons is that if you have a prolonged PR interval, AF is higher, heart failure is higher, sudden cardiac death is higher, heart failure hospitalizations is higher, and advanced AV block is higher. So patients with prolonged PR interval don't do well. And at the same time, if you offer them a therapy like CRT, in fact, you will see that the patients with prolonged PR do significantly better than patients with normal PR. So definitely this is a marker of advanced pathology and also more benefit with a therapy like CRT. So first goal, normalize the PR interval, stop drugs which prolong the PR interval like digitalis and amiodarone, implant a CRT for eligible patients. Now correcting the left bundle branch block pattern is by CRT. By doing so, you are bringing in interventricular synchrony. And we all know multiple trials have shown that there's evidence of benefit in quality of life, NYHA class, 6-minute walk test, exercise time, ejection fraction, mitral regurgitation, and freedom from hospitalization. So multiple parameters, multiple studies have shown that there's a benefit of CRT, especially in a lot of patients. Not only that, each and every trial of CRT has shown an improvement in LV ejection fraction after 6 months. The red one bars are ejection fraction after 6 months. Even after 18 months in the CARE-HF trial, you see a significant improvement, and reverse trial, further improvement, and MADID CRT, again, further improvement. So definitely an improvement in ejection fraction with the CRT therapy. So in our patients, you had an eligibility of CRT, which was offered, and we could achieve a biventricular paced QRS. However, there is a subset of patients who may not benefit with the CRT. These patients are normally with ischemic heart failures who have an extensive scar because of the myocardial infarction. And most of the time, the LV lead lands up in a scar area. The other subset which do not benefit is QRS of less than 120 milliseconds. The other goal of therapy is to prevent VPCs or ventricular tachycardias, thereby preventing incidence of sudden cardiac arrest. Frequent VPCs, as we all know, can be a marker of subsequent development of LV dilatation and dysfunction. Especially if your VPC burden is more than 20%, there's a very high chance that they may be contributing to your LV dysfunction. One of the studies which showed that if your LV percentage beats are increasing from 0.5 to almost 1.5%, the 15-year congestive heart failure risk prevent VPCs almost increases from 15% to 34%, which is extremely high. And how do you prevent that? How do you prevent ventricular arrhythmias or VPCs? Metoprolol and bisoprolol Both selective beta blockers have been shown to reduce the risk of sudden cardiac death by 41 and 44% respectively. Even carvedilol, which is non-selective, has shown that benefit of reduction in the risk of VT and VF. The sotalol amiodarone currently we don't reserve for primary prophylaxis. As we all know, beta blockers, they reduce the heart rate, they reduce automaticity, they reduce triggers like after depolarization, and they also reduce scar VT, which is the reason for ventricular tachycardia. So all the mechanisms which can give rise to arrhythmias are reduced by beta blockers. So definitely a drug which should be used more and more in these patients. In some patients where you have VPC-induced cardiomyopathy, catheter ablation shown to improve the LV ejection fraction. So if you ablate, especially patients with high burden of VPCs, you will have an improvement in ejection fraction. Preventing ventricular tachycardias and sudden cardiac arrest. The golden rule, beta blockers for everyone. Now we all know, if you have a VT or ventricular fibrillation, there's no doubt you need to get an ICD and see the improvement when you compare it with even amiodarone versus metoprolol. An ICD is far superior in reducing the mortality rate in patients with secondary or who already have a VT or VF. For primary prevention, especially ischemic cardiomyopathy with an ejection fraction of less than 35%, in MEDIT and MUST trials, there was an EP guided. So they did EP study, induced VT. They found that the reduction in the mortality rate was much more. Similar evidence has also come with sudden cardiac heart failure, which is DCMP, dilated cardiomyopathy, and definite trials, where again the mortality benefit was seen. Now, which is superior? Is one more important than the other to reduce mortality? Is medical therapy equally effective compared with implanted device? If you see all these trials, anti-arrhythmic drugs, anti-ACE inhibitors and beta blockers and MRAs have been there for last almost 20-30 years. CRT, CRT-D is almost 20 years. And if you compare, the largest mortality reduction, almost like 60%, is seen with ICD in ischemic cardiomyopathy, especially patients with class 2. The second is the beta blockers and ARNI with MRAs. When combined, you have almost a 30-40% reduction. And here you see the number needed to prevent even one cardiac arrest is the lowest with beta blockers. And when it comes to non-ischemic, the number is slightly higher. So if you compare all these combinations of ARNI with beta blocker, with MRA, ICD with ACE inhibitors or ARBs, so which is the therapy or combination which gives the maximum benefit? The ICD, the purple one, the ICD with the ACE inhibitor with the beta blocker and MRA has the maximum rate ratio reversal of 0.28, which is the maximum benefit. So as a combination, that is the superior most therapy which is going to give benefit. When you combine the ACE inhibitor or ARB with the beta blocker alone or with an ICD, it decreased all-cause mortality compared to a placebo. So ICD with the medical therapy has been found very effective and to be ranked to be among the best therapies. However, if you have medical therapy which includes only an ARNI without the device, also ranked to be among one of the best therapies. Now, if you compare all these therapies and you plot what is called as the probability rank of the therapy which will have the best treatment, the first one is the ICD with ACE inhibitor or ARB with a beta blocker and MRA. The second one is an ICD with ACE inhibitor and a beta blocker. And the third one is a ARNI with a beta blocker and MRA. So if you see the ranking wise, the first one is ICD, and the ARNI, in fact, you will see you don't need to put an ICD in some of these patients. The reason being that one of these trials showed that once you initiate ARNI, 6 months down the line, 32% of the patients who are ICD eligible have an improved ejection fraction to more than 35%. And by 12 months, this number increases to 62%. And that's why these patients become ineligible for an ICD. So in fact, ARNI is one of those wonder drugs which can also improve the ejection fraction and make these patients not need an ICD. Regarding ICD algorithms in dilated cardiomyopathy, I think there's an increased emphasis on fibrosis or late gadolinium enhancement in MRI. If you have a familial dilated cardiomyopathy, if you have a gene mutation, and you have increased scar burden or fibrosis, and ICD indicated in dilated cardiomyopathy. I think over a period of time, we may see some change in these algorithms for indication for ICD, DCNPs. Preventing AT or flutter. Of course, this patient, if she goes in AF, she is going to deteriorate. And that's why we don't want that, because heart failure begets AF and AF begets heart failure. It's like fire and fury. So if a patient of heart failure develops atrial fibrillation, first go for rate control with these two drugs, amiodarone and digoxin. And if the patient is stabilized and one knows the duration of AF, one can consider rhythm control either with electrical cardioversion or amiodarone. As we all know, amiodarone, the dose is 300 milligrams over 30 to 60 minutes, followed by an infusion over 24 hours. The second drug especially useful for heart failure patients is digoxin. It's an extremely old drug, but extremely useful in some patients. Of course, one needs to see for side effects like nausea, vomiting, anorexia, and neurological disorders. And if you see the guidelines, the ESC guidelines, heart failure with ejection fraction less than 40% for heart rate control, it is class 1 indication. Similarly, the 2014 guidelines for rapid ventricular rate in acute coronary syndrome with AF, with severe LV and heart failure or hemodynamic instability, again, one of the drugs for choice. So any patient with heart failure and concomitant AF will benefit with digoxin therapy. And catheter ablation, again, a lot of trials showing that catheter ablation may help a subset of these patients. Now, which is that subset? Patients with NYHA class 1 and 2, no ventricular scarring, mild atrial fibrosis, early stage of AF, especially paroxysmal or early persistent AF, younger patients will benefit from catheter ablation. The last is reducing the sinus rate. Why? Because we all know an increased heart rate will cause increased heart failure, increased remodeling, is increasing ischemia. And that's why you will see major vascular events are higher at higher heart rates. Cardiovascular death is higher, hospitalized heart failure is higher, and all-cause death is higher when the patient have increased heart rates. So here, a drug of choice, which has been proven in 2 trials to help, ivabradine. It causes a reversible inhibition of open HCN channels, what is called as funny channels, and that's why providing exclusive heart rate reduction. So this is my last slide. So how do you maintain the sync in patients with heart failure? Number 1, normalize the PR interval. Number 2, correct the left bundle branch block pattern, bring in synchrony, reduce or eliminate VPCs with beta blockers, prevent sudden cardiac arrest, prevent AF or flutter to maintain AV synchrony, and reduce the sinus node rate. I think I will stop here. I thank everyone for the patient hearing. Thank you.
Thank you, Amey. Wonderful talk. I leave it open now. I can see Amit and Ashish.
Yeah, thanks, Amey. It was a wonderful talk. Amey, you brought in a certain very important points, and I guess we should probably elaborate a bit, especially in terms of using of synchronized device therapy in patients with LV dysfunction. We all know that only we use these devices after attempting a good trial of optimal medical therapy. And now with the availability of ARNI and SGLT2, you've, as you rightly said, that, otherwise the figure given was up to 3 months, you should try optimal medical therapy. But some of these drugs take a longer time and you may have to wait for a longer time also. My question to you is the other way around. The example which you showed, the lady with a prolonged PR interval, wide QRS, EF of 25%, class 3 heart failure. When do you want to shorten the period in terms of deciding for a device therapy? Are there particular clinical situations or ECG echocardiographic criteria where you would say that, optimal medical therapy has to continue, you will continue that, but you will prepone the decision of putting in a device?
So this particular lady actually is an old patient of mine. She has been actually on medical therapy for almost 5-6 years now. And she was not very keen to have the device done. So she was doing well with the beta blockers and the ACE inhibitors.
So my
if the
question
patient
to you
is doing well, yeah, correct, I got it.
Not your patient, but in general, if you see an attractive,
Yeah, I'm coming to it. So the thing is that if you have, in as per this, my patient, where you had a prolonged PR, and why would want to give her a beta blocker. So there are conditions where you want to give a beta blockers, and you have a prolonged PR prolongation, and lot of ventricular ectopatics where also you would like to have a beta blocker. So that is one condition where I would definitely think considering having it. Second is atrial fibrillation or tachyarrhythmias, where the patient goes into recurrent tachyarrhythmia or AF, where again you would want to give a beta blocker or a rate reducing drug. And if you have a prolonged PR, again, you may not be able to give it the way you want to give it. So that is one other particular subset. Third is, I think, recurring episodes of LV failure. So if the patient is again and again coming back with recurrent heart failure with the ARNI on board or with the medication on board, and I see that it's not helping the way it should. Normally, we would see an improvement in their LV function and the symptomatic status in the first 3 or 6 months, at least 6 months down the line. But if you don't see that, then probably I think that is one should consider doing an echo and seeing the EF and evaluating whether this is lady or the patient is eligible for the CRT.
Ashish, any comments from your side?
I mean, I wanted to, I enjoyed Amir's talk completely. I mean, he answered probably most of my questions, but I just wanted to discuss the atrial fibrillation part with him. Atrial fibrillation is a dampener in heart failure management. It increases the hospitalization, it increases the mortality. And in patients who have devices, it creates trouble. For example, in patients who have ICD, it can lead to inappropriate shocks. And in patients who have CRT, it can reduce the biventricular pacing. So just to reorient, Amey, what you said for the audience, a patient has a CRT, how would you deal with such a patient who gets a paroxysmal AF, who gets a persistent AF, and who has a permanent AF?
Right. So if it comes to rate control, then of course the drug would be beta blocker on choice. Regarding paroxysmal AF, normally we would recommend to give at least amiodarone for a period of 3 to 6 months and see that they are on the maximum tolerated dose of ACE inhibitor or the ARNI, because that will cause some LV remodeling and reduce chance of the LA dilatation and patient going into atrial fibrillation. Regarding permanent AF, again, I would, if the patient is having a fast ventricular rate, I would give digoxin as one of the drugs so that we can get the ventricular rate under control. And the other thing is that the device programming as a tool, which we have a lot of SVT, VT discriminators, which will help like EGM template matching or the stability and the onset of the tachyarrhythmia. So these 3 parameters one can turn on so that there is no inappropriate shock where the patient goes into ventricular tachycardia or AF with fast ventricular rate, and there is no inappropriate shock. So at least some programming in the device form so that you can take care of these inappropriate shocks.
And when do you use sorry, when do you use AV node ablation in patients who?
So I think at least I would keep it as one of the options if you see that the percentage of BIV pace is less than 90 or 95%, especially because of high ventricular rates. If it is because of high VPC burden, then it is not much likely to help. But if you see that the VPC burden is not much and still the ventricular percentage is less, and you can see the rate histogram in the CRT to see what is the rate, varying up to going up to. If you see that the rate is always high in spite of the medication on board, then that is a particular subset. But again, that is actually almost like a last resort. When all the medications fail and still the ventricular rate tends to be high.
One question would be, when would you use NOACs in patients who have device detected AF? Do you have a good answer for that?
So there is a lot of controversy whether we should use or not use. Some people say that up to a 30-second interval of detection is enough. And normal recommendation is that at least do an ECG, confirm that is atrial fibrillation, and then start the NOAC. That is one logical way of doing it. But if your device is showing a large AF burden, because if you see the dynamicity of AF, it could be for a few hours in a day, or it could be multiple occasions of few seconds in a day. But if you see the overall burden of AF, I feel that if your AF burden is much more, then I would definitely warrant anticoagulation on board.
Amey, one question. As far as biventricular pacing is concerned in patients who have got LV failure or dysfunction in this, what about his bundle pacing?
Yeah, his bundle, I was going to talk about it, but because of lack of time, I skipped it. So slowly, gradually, I think it is coming into the picture because there are a lot of patients with CRT who don't do well, and you may not get a good LV lead positioning. So there, especially his bundle or what is called as left bundle placing, and correcting the left bundle block is having some role. So it's like hot CRT is called as. So especially for patients who are not eligible for CRT, who don't have a good vein, and again, I think affordability, if you can, because here you can, with his pacing, you can get away with a dual chamber pacemaker. So those patients, one can consider doing this as an option. And I think now there are a lot of, I think 2-3 trials which have shown that it is quite effective, if not as effective as CRT.
Thank you, Amir. Thank you so much for a wonderful talk. And thank you, Amit and Ashish, for your inputs on this particular talk as far as Amir is concerned. Let's move on. Thank you. Let's move on to the case presentations. The first case is going to be presented by Rahul, and it's about clinical case scenario highlighting the decision making in heart failure. Rahul, and we have two experts who are going to take the talk forward. That is Dr. Satyavan Sharma and Anvay Mule.
My talk for the day is about case of heart failure with reduced EF, and once the EF recovers after starting the optimal medical therapy, what various discharge protocols do we follow and how do we follow up these patients? So let's go through a small case study. This was a 78-year-old lady who was hypertensive for around 20 years. She was also had dyslipidemia for the last 5 years, and she was on treatment for the same. The medication for blood pressure she was taking was carvedilol 12.5 milligram, a combination tablet of losartan 50 milligram, amlodipine 5 milligram, and hydrochlorothiazide 12.5 milligram once a day. So this was a regular regime for the blood pressure medications. At least for the past few years, she has been maintaining that. The earlier blood pressure readings were not very well known because she was not having a good follow-up for the last couple of years, considering the COVID. But earlier to that, she says the blood pressure was well controlled. She presented to the emergency department with complaints of sudden onset breathlessness of 3 hours duration. She had stopped all her blood pressure medications for the last 1 week. This was a confusion by her dentist, who had advised her to stop the blood thinning medicine because of some tooth extraction, but she misunderstood, and the miscommunication led to stopping of all the blood pressure medications for the last 1 week. And thereafter, she presented with acute failure. On presentation in the emergency department, her blood pressure was 210 by 120 millimeters of mercury with a heart rate of 120 beats per minute. She had bilateral crepitations, tachypnea, and a saturation of 76% on room air. Her ECG, quickly done, showed a sinus tachycardia with frequent ventricular ectopics and left ventricular hypertrophy. Actually, on the monitor, there were frequent couplets and triplets also seen occasionally. Her bedside echo was done, which showed a concentric left ventricular hypertrophy and an LVEF of 30 to 35% with generalized hypokinesia. The initial treatment was started with the provisional diagnosis of hypertensive heart disease with acute left ventricular failure. She was put on non-invasive ventilation. She was given bolus doses of furosemide, and she was started on nitroglycerin drip for blood pressure control. And in view of the ill-sustained ventricular tachycardia on the monitor, she was also started on injection amiodarone, 300 milligram bolus followed by 900 milligram infusion over the next 24 hours. So with the initial treatment of diuretics and a positive pressure non-invasive ventilation, she definitely improved. Her oxygenation gradually improved. And by 24 hours, she was off the NIV and maintaining on nasal prongs. And her blood pressure was gradually controlled. Her other investigations revealed that her cardiac enzymes, that is the troponin I, was little high, and that was more than 3 times elevated. It was 0.07. Her NT-proBNP was also high with a value of 7,800 at admission. The other parameters, her hemoglobin was fine, and her renal functions were also normal. So she was initially started on dual antiplatelets as well because her cardiac enzymes were positive and a low molecular weight heparin. In therapeutic doses, she was her amiodarone infusion after 24 hours was switched to oral amiodarone, and her calcium channel blockers were initiated. Initially, amlodipine was started at 5 milligram twice daily dosing, and then we could gradually get rid of the NTG drip. After 24 to 48 hours of stabilization, sacubitril valsartan combination was started. And after 48 hours, her IV furosemide was also switched to oral furosemide. So she was shifted out of the ICU after 48 hours. Beta blockers were initiated after 72 hours once she was stable and dry. Thereafter, she was also evaluated in view of the raised cardiac enzymes and LV dysfunction for a coronary angiography. The coronary angiography showed significantly calcified vessels, but they were with plaques, but there were no significant stenosis anywhere. Also, the renal angiography was done in view of the accelerated hypertension, but there was also no significant lesions in the renal vessels as well. So by day 5, we were almost set for a discharge, and her blood pressure was well controlled. The medication regime she was on was valsartan sacubitril combination of 50 milligram twice a day, amlodipine 5 milligram twice a day, metoprolol 25 milligram twice a day, furosemide 40 milligram in the morning and 20 milligram in the afternoon. Apart from that, she was kept on a single antiplatelet aspirin 75 milligram in view of the coronary artery disease, and rosuvastatin 10 milligram was also continued. Her renal functions were fairly good. Her GFR was almost 80. Her NT-proBNP came down to 3,200 from 7,800. Her 2D echo was repeated before the discharge, which showed the LVF improvement from 30 to 45%. Her heart rate was around 64 at discharge, and blood pressure was very well controlled with the present regime at 130 by 70 millimeters of mercury. So we all know that at discharge, these patients are very vulnerable. We feel that these patients have stabilized, but we need to be very carefully monitoring few things at discharge, and few clinical things like clinical signs of heart failure, like has the edema come down completely, has the RALs completely gone from the chest, how are her oxygen levels, has the tachycardia settled completely or no, how is the blood pressure well controlled or no. So these few things we should be very careful. Also the renal functions, including the electrolytes, because many a times we are giving them so much of diuretic, so hypokalemia is very common. Once they start, some patients do get AKI and then they come into the diuretic phase, so we should be very carefully monitoring electrolytes. And also, I feel that we should do an NT-proBNP pre-discharge, because this becomes a baseline NT-proBNP to compare it with further in case any events are there or for follow-up in that matter. So we all know that these patients of acute decompensated heart failure are vulnerable patients. Approximately 1/4 of these patients get readmitted in the next 30 days because of a repeat heart failure episode. And some of them go into chronic heart failure, and the mortality during this 30-day period can reach up to as high as 10%. So these two things, the morbidity regarding the readmission and the mortality, these both has to be very, very carefully looked into. And the easiest way to do is optimize these patients with adequate medical therapy at discharge. So there are few recommendations by the Heart Failure Society of America about the discharge criteria which are recommended for all heart failure patients. So first of all, the exacerbating factors should be addressed. Like in our patients, we had the drug adherence was not proper, so she was explained about it. But apart from that, anemia, any ischemia or any infections can precipitate this, so they should be treated optimally. The patient's volume status should be observed very carefully, whether they are dry. They should not become over dry, because then they can go into renal failure. So we should be very careful about that. They can get symptoms related to hypertension, or on the other hand, they can still be edematous. So an optimal volume status needs to be adequately optimized before we discharge them. Transition from IV to oral diuretic should be successfully completed. I would suggest that at least 24 hours, these patients should be maintained well on oral diuretics. If they are maintaining well, then only we should plan for a discharge. Patient and family education should be completed, including the clear discharge instructions about the salt restrictions, water restrictions, other lifestyle restrictions, and the importance of taking medications regularly, and the regular follow-up should be done. LVF should be documented because that's the baseline thing. Smoking cessation and other counseling regarding any abuses should be done, started. Near optimal pharmacological therapy should be achieved, including ACE inhibitors or ARNIs and beta blockers. And they should be followed up in the clinic visual, usually 7 to 14 days after the discharge. Now, patients who have recurrent heart failure, they should be more closely monitored. They should be on an oral medication regime for 24 hours, no IV vasodilators or inotropic agents for 24 hours. They should be ambulated before discharge to assess the functional capacity after the therapy. And plans for post-discharge management, that's a scale present in home, visiting nurse, or telephone follow-up, generally no longer than 3 days after discharge, and the referral for disease management if it is available.
I think we should.
Now, there is a beautiful chart which was recently been published, was about the medications optimization chart. So this is a very beautiful chart. I think we all should have for all the patients, and they are just outlined the drugs which we use for follow-up, like the armies. At all steps they have used it, from transition from ICU to wards, at discharge, at the follow-up visits, and the subsequent follow-up. So the doses, which drugs we are giving, and if it is not prescribed, what is the reason? So either ARNI or ACE inhibitors or ARBs, then beta blockers and MRAs. These are the mineralocorticoid receptor antagonists. Then diuretics also should be optimized and gradually reduced. Apart from these standard therapies, any additional therapies if they are given, IV iron with the anemia, which is very, very common and precipitating factor for heart failure, should also be considered. Whether they are optimally vaccinated or no, they should also be followed up clearly. And whether they are planned for any device, if yes, why, if no, why. That we should think about each and every patient at each and every step. So once they are discharged optimally, we usually recommend them to follow up initially after 10 to 15 days for the first follow-up, and then every 3 to 6 months, depending upon the clinical scenario. So the adjustment of therapy should be considered every 2 weeks to achieve the guideline-directed medical therapy. We all know that RDs, if they are titrated well every two weeks, then the patient tolerate it at maximum doses and they get maximum benefit out of these therapies. And echocardiogram should be repeated.
I think we have exceeded the time, Rahul. We will go on to the discussion. Dr. Satyavan Sharma, are you there, sir?
Yeah, good evening.
Yeah, and Anvay, yeah, please.
Yeah.
Please give your inputs on the, basically, I think he's talking about a patient who has come into failure and then has been treated and has come out with an LVEF, which has improved by almost about 10 to 15%. So how should be the management as far as these type of patients are concerned?
Ajit, can I start?
Yeah, please.
Okay. It was a nice talk, Rohit. Let me give a little bit twist to your case, because the case is looking actually very straightforward to initiate any large discussion, because I think every one of us, while discharging this patient, will keep him on all the heart failure medication, as you very rightly emphasize. Now, let me put you a scenario. This patient comes to you for follow-up after 3 months, then again after 6 months, and then again after 8 months. And now this patient's ejection fraction has become almost like normal, and all echos have been done in just load. And ejection fraction now says 55%. What will be your approach?
That was my last slide, actually, that once the patients which had not come, that once the patient's heart failure symptoms improve completely and the heart pumping improves to normal, then how long do we continue the therapy of heart failure management. So like sacubitril valsartan is one thing that now when do we switch over from like ARNIs to an ACE inhibitors or ARB based regime, or we don't do that because such a patient has got some form of structural heart disease in the form of increased LV mass, and they will be prone to developing heart failure symptoms again in the future. So whether we stop the therapy after 3 to 6 months or do we continue it for lifelong?
Right. So I wanted you to give us a bigger, broader message that in those patients who LV ejection fraction has improved is not synonymous with the patient's improvement of his heart disease.
Yes.
The patient is still has some structural disease or anti-BroPNP is elevated. So we have to continue the medication, possibly long term without any interruption.
So it will be primarily depending upon the etiology of the underlying reversible heart diseases. Like if suppose the patient had myocarditis, then or some form of stress cardiomyopathy, then we know that these patients are going to improve and may not be requiring long-term heart failure management. So once we are confident that these patients have recovered completely, we can get rid of the heart failure management slowly and then switch back to the regular management and prevent such circumstances in which they develop it frequently. But if such patients are there, like a hypertensive heart disease, which I think is a common phenomena, I would suggest that we should continue it for a longer time, because these patients will again be prone to develop such problems in future.
Rahul, actually the biggest challenge is there are no guidelines for treating such patients.
Yes, sir.
Absolutely.
And even in stress cardiomyopathy and myocarditis, we have seen recurrences. We all have seen recurrences,
Yes, sir.
I think the clinician has to individualize depending on what he feels best for the patient.
Yeah. Thank you, Dr. Sharma. I think we'll move on to the next case, which Dr. Mehran is going to present. Yeah, Mehran. Can we have the last case, please?
Hello, am I audible?
Yes.
Can you please project my slides, please?
Yes, sir.
Hello, good evening, everyone. My name is Dr. Talha Miran. I am a heart failure and transplant cardiologist at Sir H.N. Reliance Foundation Hospital in Churni Road, Mumbai. I have been asked to discuss an interesting case in heart failure that was successfully bridged to cardiac transplant, focusing mainly on the clinical decision pathway in such complex cases. So let's begin. Our case in question is a 45-year-old diabetic woman with a history of hypothyroidism who was transferred to a center for management of cardiogenic shock. 1 month prior to this presentation, she had anterior wall MI. Coronary angiogram done at that time showed 100% occluded LAD with only mild lesions in the RCA. Echocardiogram showed a LVEF of 35% with no significant valvular abnormalities. Despite multiple revascularization attempts by at least 2 different cardiologists, the LAD could not be opened. After that episode, she was discharged home. However, she had 2 subsequent heart failure hospitalizations. Her repeat echocardiogram showed a significantly dilated LV now with LV-EDD of 68 millimeters and an LVEF of 10 to 15%. On her second such heart failure hospitalization, she was intubated on mechanical ventilation, started on inotropes, dobutamine and adrenaline, and transferred to our center. At the time of presentation in our emergency room, her blood pressure was soft with a MAP of 70. Saturation was borderline on 50% ventilation, FiO2 on the ventilator. Her blood work, just to quickly summarize, creatinine, LFTs were normal. White count was normal as well. Lactate was top normal at 1.5. NT-proBNP was significantly elevated, and the ST2, which is a marker of myocardial fibrosis, was significantly elevated. ECG showed anteroseptal Q waves with ventricular bigeminy on the telemetry. Her echocardiogram showed severely dilated left ventricle with entire apex anterior wall as well as a good fragment of the anteroseptal and the inferolateral wall being completely thinned out and aneurysmal. Thankfully, no mechanical complications of MI like VHD or MR could be seen. The admission chest X-ray showed, as you can see here, pulmonary edema with some right lower lobe haziness. She was making a decent amount of urine, about 60 to 70 ml per hour. So at this point, we have a patient who is in heart failure, visibly based on the NT-proBNP and the chest X-ray on inotropes and dependent on inotropes. So at this point, we needed to make a decision what to do next, whether to step up diuretics. Can we wean the inotropes, continue inotropes, since the end organ function was fine and lactate was normal. So in order to get some more objective information, we put in a Swan-Ganz catheter at the bedside, which showed these numbers. The CVP and wedge pressure was significantly elevated as expected. There was group 2 pulmonary hypertension, which severely reduced cardiac output and severely reduced cardiac power output as well. Mind you, these numbers were already on inotropes, so her cardiac output was extremely low with a high systemic vascular resistance. So she was in Sky stage C shock, and according to the Intermax registry, she was a level 3 on the Intermax profile. So based on this information, we step up the diuretics, put her on a diuretic infusion. With that, her urine output was good overnight, total of about 1.8 liters. However, the tachycardia worsened, ventricular arrhythmias worsened, the heart rate shot up momentarily to 140s, 150s. This made us wean off the adrenaline, lower the dobutamine, but the MAPS, the mean arterial pressures now started to dip as well. And with that, her saturations also went down from 95, 96% to about 90 to 92% with increasing FiO2 requirement on the ventilators. The lactate also started creeping up from 1.5 in admission to 2.5. This was her repeat chest X-ray, still showing pulmonary edema, but now the right lower zone haziness, which was much more pronounced. What to do next? Should we go in with a balloon pump? Increase the inotropes? What to do next? So again, the Swan-Ganz catheter came to our rescue. Swan-Ganz catheter now showed a PA saturation of 64% with a very low SVR. So this showed that this was a little bit more non-cardiac element that may have led to the decline overnight, maybe a septic element. So with that in mind, we added pressors, decreased the dobutamine, and the antibiotics were stepped up. With that approach, over the next 72 hours, her lactates normalized. The ET, the endotracheal tube cultures grew gram-negative bacilli. Blood and urine cultures remained negative. With appropriate antibiotics, her chest X-rays improved and she was able to be extubated. The dobutamine was weaned off. She was on very low-dose NORAD and low-dose adrenaline infusion, as you can see here. Her cardiac output and cardiac index had settled to somewhere around 3.7 and 2.6 respectively, with a mildly elevated SVR on these inotropes and pressors. So the plan was to go ahead and try to wean off the adrenaline gradually. However, no sooner that the adrenaline was weaned off, the NORAD requirements went up drastically. The lactates went up again. The cardiac output and the cardiac index dropped from 2.6 to around 2, and the SVR went up. So looking at these changes, we thought maybe milrinone would be a good option, keeping in mind that she may also be someone that may need home inotrope therapy. So milrinone would be a good option to try. So we trialed milrinone. However, this failed miserably. The systemic blood pressures fell down, prompting increase in adrenaline as well as NORAD infusions. By this time, on antibiotic therapy, the repeat endotracheal tube cultures were negative. As I said previously, the blood and urine cultures were already negative, so she was infection-free from all standpoint, and we were not really making any overall improvement in the clinical picture, so we registered her for cardiac transplant. Now that the patient is registered for cardiac transplant, our next task is to make sure that she is alive and well till the transplant. She's getting good nourishment and she remains infection free with active physical therapy going on. So what about our options now? She is on adrenaline and NORAD infusions, as you can see here. So what do we do? Should we just keep continuing the inotropes? Maybe try another different combination of inotropes? Should we put her on a mechanical circulatory support device because we are not able to wean the inotropes? Again, if so, what would be the options for our mechanical circulatory support devices? Given the aneurysmal LV apex, any kind of apical cannulation with a temporary or permanent LVAD device would be extremely dangerous and surgically complex. So the options were maybe an Impella or a subclavian intra-aortic balloon pump, so that with these inside, we can still be able to mobilize her, get her to do physical therapy until we do the transplant. So after a detailed clinical meeting discussion with the family, we decided to go with levosimendan. We gave her our 24-hour protocol for the levosimendan. With the levosimendan, thankfully, the pressure requirements did not go up. No arrhythmias were reported. Her PA saturations, cardiac output improved significantly, and organ functions also remained okay. After about 4-5 days of levosimendan infusion, we were able to go down on the adrenaline. We started to mobilize her and give her active physical therapy. Finally, after 7 to 8 days of levosimendan infusion, we were able to wean off the adrenaline completely. The lactates remain normal. The end organ functions, the creatinine and the LFTs remain normal, and she had good urine output. And so we finally removed the Swan-Ganz catheter. After 3 days, luckily, she was still in the hospital. We received a favorable donor offer. She underwent the cardiac transplant and eventually discharged home on post-op day 13-14 of cardiac transplant with absolutely normal end organ function. This is her echocardiogram after the transplant, as you can see, beautiful normal biventricular function. So with that, I would like to end my presentation. Thank you for your patient listening.
Thank you, Mehran. Wonderful case. I think we leave it open for Dr. Satyavan and Dr. Anvai.
Hi, sir. Dr. Satyavan Sharma, sir. So in such patients, of LV aneurysm, I think the such a severe fibrosis, and when the ST2 levels are like 77 plus, and when they had 2-3 failures, failed angioplasty, came on a ventilator and on inotropes, I think the Swan-Ganz and simple Swan-Ganz, which you taught us in our MBBS or in cardiac surgery time, has helped us to come with the good diagnosis. I think that use of the Swan-Ganz in such patients is very, very essential and important. And I don't think such patients, just aneurysm or RAFI helps in these patients to come out of the problem. I think the transplant is the best solution and the outcome.
Anvai, one question from my side.
Yeah.
When patients come for you for transplant, and if they have a history of a short history of left ventricular failure, would you go ahead and do the right heart catheterization for all the patients?
Yes.
Okay. You want to assess the pulmonary vascular resistance in all of them.
Because the new heart what we are putting does not know what is high pulmonary vascular resistance. They are never used to, they are never exposed to. And when they are suddenly exposed after the transplant, in front of us, the right ventricle fails.
Okay.
Dr.
Sharma?
May I add something to that?
No, I think, this is the case, of course, we have to learn from Anvai and his team and Manan. Actually, I think what we as all the cardiologists should learn is that since the transplant is a reality now in our city, we should start looking at the cases much earlier rather than sending the patients, as a last option. Because in some patients, it becomes absolutely clear that, these are the patients who are unlikely to improve beyond a point. So I think those patients should be alerted early so that, they can give us the best results.
Absolutely.
I think the most important, Ajit, in this case, what sir is saying is that once you recognize the possibility of they going in repeated failure, when the ST2 levels are very high, when your LVIDD is more than 4 centimeter per meter square area of the body surface area, in such patients, it is better to list these patients on a waiting list for a transplant. When the time comes and if there is a call for a transplant, if they are really doing good and they don't want it, they can. Number remains up, and that is very important because, as Sir said, when they deteriorate in the graph, we never know, and it is impossible to predict that.
Any age cutoff, Anvay? Anything younger as well as old?
For recipient there is no age cutoff. However, we look at all the as wholesome as on these patients about their diabetes, about their kidney problem, about their other. They must.
I think we have
decide to put LVAD in this patient, the right ventricle should be in a good condition to tolerate that. So there's a balance between the right ventricle, pulmonary vascular resistance, and a heart failure.
Yeah, Anvay, the last question from my side is, if you have patients who do not get the heart in the specified time, you cannot predict as to when you will get the heart, the transplant. So how do you manage these patients? Are you going to keep them and the chances of them going into repeated failures and things like that?
So we had started this program of milrinone at home, and it works for some. In some patients, the milrinone is not tolerable. They can't tolerate the milrinone, and those patients, then we cannot send them at home. In such patients, either the Cosivad or ECMO or a Centromag, which is a temporary LVAD device. So we had some patients, as you rightly said, we have got 3 or 4 patients for whom the LVAD, Centromag, temporary LVAD was put from 30 days to almost 46 days. And finally, they got the transplant. Those who could not get a heart even after the mechanical circulatory support, the mortality was 100%. But those who get the mortality was 0%, means zero mortality. Those who got a heart transplant.
Thank you, Anvay. Wonderful job you have been doing, you and Mehran. Fabulous job. Now, we have come to the end of the webinar today. Wonderful talks by most of the speakers. I hand over to our secretary, Dr. Uday Jadhav, to give the closing remarks, please.
Thank you, Ajit. Thank you, Ajit. So let me first both congratulate and thank you on behalf of the entire CSI Mumbai and the fraternity of cardiology through our city and your colleague coordinators, Dr. Nihar Mehta and Dr. Zakia Khan. This was a wonderful meet. To summarize very quickly, and let me first say this, we are at 10 o'clock. It's fantastic this way to maintain a time. We must stick to this for all our future meetings. So without taking the names of our illustrious faculty, what we did today and have an understanding is this, that as Ajit started with, that we need to have a clarity on the classification of heart failure, and we now know that it is a clinical syndrome. Pay attention to the clinical symptoms and signs, which are at least the signs which are taking a background in the COVID days, but still we need to look at it carefully. We need to better our echo skills. Strain imaging is there. GLS has to be utilized in a better and better way. There is sensible information we get. CT and MR in particular, not CT, MRI has to be utilized in a better way in all those patients where you get cardiomyopathy specifically and the infiltrative diseases also. That's what Bhavin explained as well. You have HFrEF and HFpEF. HFrEF now is organized care with SGLT2 inhibitors being added to ARNI and the MRAs and the beta blockers. We are absolutely sure how to get down the mortality by 75%. Sacubitril, valsartan, and the SGLT2 inhibitors together. Let's not now say they are different drugs and when do you start one before the other is going to make an impact on the therapy of heart failure. HFpEF is going to be a big enigma. The only probable drugs that will come up are SGLT2 inhibitors. Emperor Preserved will be presented with empagliflozin in this ESC, so that drug is already on. And then we talked about right ventricle. We talked about the arrhythmia management, the exact role of devices. And then we had 2 cases, great cases. And what Dr. Mehran and Dr. Anvay Mole pointed and Dr. Satyavan Sharma sir said, and is very important for all of us to remember. Let's not push heart failure beyond the level where we offer them nothing. The heart transplants and the devices and LVADs, affordability is one aspect, is not for end-stage heart failure. You need to first define and understand who are the patients who are going to benefit. If we do that, we will make a great human service to this patient who endlessly otherwise suffer, because all drugs eventually reach a full stop. With these closing remarks, thank you very much, Ajit, Sadanand, thank you the entire team, and let's carry this CSI webinars in this best way forward. Thank you.
And Uday, also thank the sponsor for our
Yes, Novartis. They have been our educational partners for this. And like one of those very, very good standard companies, I have signed their documents on behalf of CSI Mumbai. Very straightforward, very simple, very easy to get on in an educational partnership meeting. So thank you. And Vama, of course, we should never forget
of
that.
Course.
Swapnil does a very good job for all of us. Thank you very much. Thank you, everyone.
Thank you, everyone.
Thank you. And a great weekend ahead.
Thank you. Good night.